This paper looked at the relationship between physical activity, cardiac dimensions, and HFpEF. And this is of direct relevance to sex differences in HFpEF development, but also activity and function, particularly given the figure on the right demonstrates that at any age, women have a lower VO2 peak and they fall below the threshold of functional independence much earlier than men do. I'll refer you to the paper for a lot more detail, but essentially he describes that small ventricular cavity size is associated with increased chamber stiffness, meaning that challenges such as volume loading or exercise are more likely to precipitate pulmonary edema. Typically with aging, the heart does become smaller and stiffer. However, exercise training will attenuate these changes. However, physical activity inactivity throughout the life course will predispose to the development of HFpEF. The lower physical activity and cardiorespiratory fitness amongst women, coupled with the smaller chamber geometry and somewhat blunted cardiac chamber enlargement in response to physical training as compared to men, may help to explain the higher prevalence of HFpEF in women. To investigate these factors and how they may impact physiology and hemodynamics in HFpEF in women versus men, we looked at patients referred for an exercise right heart cath, and this is a video of the procedure that we use in Melbourne, with symptoms and clinical features suggested of HFpEF, but they had equivocal resting status. Exercise is integral to the diagnosis of HFpEF, particularly in patients in the earlier phases of the disease who may have normal resting filling pressures with a dramatic rise in pressures with exercise. You can see an example of a patient here where the resting pressures at baseline fell within the normal range. However, with leg elevation, but then subsequently exercise particularly, there was this dramatic rise in the wedge pressure. And you can see this illustrated in the initial description of the response of patients with HFpEF to exercise from a wedge pressure perspective that was described by my director, Professor Kay, back in 2013. These tables are from my research during my PhD, and this is where we looked at sex differences amongst all patients with HFpEF evaluated with right heart catheter studies with exercise. You can see that women were overrepresented amongst this cohort. And in terms of their baseline comorbidities and epidemiological factors, the only significant difference was that of ischemic heart disease being more common in men. However, there were numerous differences in the hemodynamic scene, and as you can see, the wedge pressure was higher with exercise when indexed to workload or stroke volume, and particularly the delta. They also had lower stroke volume and stroke volume recruitment. And we then did some calculated values derived from the measurements taken, including compliance, which reflects arterial stiffening, and also mirrors multiple studies in the literature demonstrating higher arterial elastance in women. And systolic elastance, reflecting ventricular stiffness, was even higher in women accordingly. The arterial ventricular coupling ratio was lower in women, indicative of impaired pairing of the arterial and ventricular systems and affecting functional capacity. And this figure really summarizes the findings of that paper, which is that there's a complex interplay of factors that affect exercise tolerance in women with HFpEF. They have central to this elevated filling pressures, and multiple factors reflected that. They also have higher systemic vascular resistance and lower compliance, and that's something that we talked about in terms of the predisposing factors. Importantly, they also had impaired peripheral oxygen handling with higher lactate response to exercise, which may reflect that they have poorer skeletal muscle conditioning as well. And then also they had impaired pulmonary vascular function, which may reflect chronicity, but may also be an independent worsening in women compared to men. This is a really fantastic paper from Jennifer Ho's group in Boston, looking at contributors to exercise limitation and how they affect women versus men with HFpEF. They evaluated almost 300 patients, of whom almost 60% were women. And despite having fewer comorbidities and reaching a similar percent predicted exercise capacity based on VO2 max compared to men, women had distinct deficits in multiple components of the oxygen utilization pathway. This included lower maximum voluntary ventilation, worse biventricular systolic reserve, worse diastolic reserve as measured by the wedge pressure to cardiac output slope, and importantly, poorer peripheral oxygen extraction. And so these factors were examined in multivariate analyses, but persisted nonetheless. There's a similar paper that was published. This is just an abstract from ACC this year that similarly found greater impairments in exercise performance in women as compared to men with HFpEF. And together, these studies highlight more severe impairments relevant to physical function in women with HFpEF, with adverse hemodynamic profiles and lower exercise capacity. Just to finish, I'll just talk about some of the factors in terms of hospitalisation. So there's been sex-specific analyses of several HFpEF trials, and they've shown similar rates of hospitalisation and a lower risk of death in women with HFpEF as compared to men. So on the left, we have an analysis of the iPreserve trial that included approximately 2,500 women. And on the right, we have an analysis of HFpEF patients included in the CHARM-preserved, iPreserve, and TopCat America trials. And consistently, what they demonstrated is that women seem to have better MACE with poorer quality of life overall. So just to finish and open up to questions, this is a figure from our review on sex differences in heart failure more broadly, but it's just highlighting that there are still significant knowledge gaps with regards to the prevention and management of heart failure in women. I think the physical activity rates do have a lot to do with this. Reflecting back on that paper regarding cardiac chamber size and physical training from Dr. LaGersh, but there appear to be a number of other abnormalities beyond this, and hopefully we can build on this knowledge to improve on the health of women in the future. Thank you.
Thank you, Dr. Annabelle. Thank you for that masterclass on HFpEF and pulmonary hypertension. Dr. Anna, as your work in Australia shows, you deal with multiple races there. So do you see race differences as well as sex differences in your studies?
We do, but the size of our data sets that we've analysed ourselves are not substantial enough to look at those subgroups specifically. So unfortunately, we don't have differences in terms of race, and I think that would be really helpful because I believe there would be significant ethnicity-related changes in terms of vascular performance. We know that that is something that we see in heart failure more broadly. And also it would be really interesting in knowing how cultural differences in physical activity may affect the development of HFpEF. So that's certainly something that would be worthwhile exploring.
Thank you, Dr. Ko. You have mentioned that, and Saira has asked half of my question. I just wanted to have your impression about this in your population regarding races and socio-cultural. You know, I've been working on it for the last 2 decades, and in my observation, in our part of the world, it is very high fertility rate coupled with low socio-economic condition. So what happens is, poor women is made pregnant every year with very little resources to meet the needs of both mother and the child, and with joint family system, tremendous mental stress. What happens, and then certain myths that a woman after delivery should not leave the bed for 40 days. So what happens, it gives rise to obesity, which in turn degenerates into hypertension and diabetes, and finally heart failure. Now, you know, before that we just called it heart failure, before the concept of preserved ejection fraction. I would see these poor obese ladies coming to the clinic, panting like anything. Oh, she's functional. She's having some psychiatric problems. At the most, she would be referred to pulmonologist. But I think it's a very important factor, and the socio-cultural and the racial thing is very important in that. Thank you. Thank you for your lovely talk.
Thank you, Dr. Nusrat. Professor Tahir, do you have any comments?
One question from Ku. Is it physical inactivity or it's the smaller cavity, LV cavity, that's leading to higher heart HFpEF in patient, particularly women compared to male?
I think it's both. I think they have an intrinsically smaller cavity, left ventricular cavity size, but then this is exacerbated by lower rates of physical activity. And I can say that the Australian population in general are quite active, but I rarely have women who have a history of significant physical activity through their lifetime that end up in my HFpEF clinic. I will also say, to the point about multiple pregnancies, I also have a study indicating that women with 3 or more pregnancies are more likely to have HFpEF. However, I think it's very difficult to control for those other factors, such as, the associated demands of parenting and inability to do physical activity. So I think it's all very closely intertwined.
Thank you. I think in the interest of time, we will move forward. It was a privilege to hear from an expert, and we hope to continue this conversation further. Dr. Natalie Koh has joined us from the National Heart Center in Singapore, and she will be talking about something which is very intrinsic to the Go Red for Women movement, gender and cardiovascular health, why are women left behind? Dr. Natalie, please go ahead.
Dr. Fawad, please join us.
I'm so sorry. Dr. Fawad, do you have a comment? Okay, maybe for the next one then. Thank you. Dr. Fawad, please join us on stage.
Good evening. I'm trying to get my PowerPoint to be shared. Just a short while. Okay. Try this. Okay. Are my slides able to be viewed, please?
Yes, we can see it.
Thank you so much. And thank you so much for the kind invitation. It is truly a privilege to be invited to sit at the table and to learn from all the experts present today. I'm Natalie, and I'm from the National Heart Center in Singapore. And thank you for inviting me to speak about gender and cardiovascular health and to discuss some of the reasons why women are left behind. I think this is not news to us that there is a silent epidemic when it comes to cardiovascular disease amongst women globally. Cardiovascular disease kills more women than all cancers combined, and this was known from 2011, and nothing has changed 10 years later in 2021 when Lancet published their Lancet Women and Cardiovascular Disease Commission. Nothing had changed in all these years. Women remain underdiagnosed, undertreated, and underrepresented in research. And I think there are many studies that have proposed various reasons why, and we can look at it from both a biological as well as gendered risk factor perspectives. Some of the biological differences include sex-specific risk factors, such as pregnancy-related complications that was fervently discussed in the previous talk. Known risk factors include women who have had to endure pre-eclampsia, gestational diabetes, pregnancy-induced hypertension. Other sex-specific risk factors include early menopause and women who have autoimmune disease, such as lupus and rheumatoid arthritis, which affect women more than men in a ratio of 4:1. Unique pathophysiology to women include their later presentation of CAD, coronary artery disease, in their postmenopausal years, spontaneous coronary artery dissection, microvascular angina, and Minoca, which has received some headlines in the last 2-3 years. Specific gendered factors include social cultural barriers and systemic biases in various healthcare systems, not just unique to, I think wherever we come from in the various healthcare systems we represent, whether it's Australia, Pakistan, or Singapore, I think this is quite common and we see it anecdotally in our practice. There tends to be delayed care seeking among women, sometimes some provider bias as well. And importantly, what is borne out in the literature and well published is that women are also more likely to present with non chest pain symptoms such as fatigue and nausea. And the American Heart Association, since 2019, has been doing lots of public outreach. This is one of their publicity material to inform providers as well as patients, potential patients, that not everyone presents with chest pain when it comes to a heart attack. For women specifically, they tend to present not always with chest pain, often a pressure or a pain in the lower chest or upper abdomen, frequently simply nondescript findings of shortness of breath, some fainting, perhaps indigestion, or simply fatigue. Then there is also the research gap that contributes to this silent epidemic. And historically, clinical trials have excluded women or failed to analyze sex-specific outcomes. I'm so grateful to learn that Dr. Anna Beale, in the course of her PhD work and with various consortiums, has done so much to address this gap. Many congratulations to the excellent work presented, especially to HFpEF. And even in preclinical studies, in phase 1-2 trials as well, often male animal models are used, skewing drug development right from the beginning. And it's also reported in the literature, adverse drug reactions are actually more common in women because they were not tailored for women. And it began even in preclinical trials. So this is a study by Accenture, just published 3 months ago, specifically to draw your attention to the cardiology trials, coronary heart disease. Only at best, 35% of trial enrollees were female. And in terms of reported disease cases, despite the underrepresentation in trials, women accounted for 44% of the adverse outcomes. There are also disparities in care. And we know from the literature that women are less likely to receive statins, revascularization, or even guideline-directed therapy. In one study, only 54% of women with heart disease received cholesterol-lowering medication versus 74% of men. And in this study, the questionnaire actually revealed that perhaps implicit bias and age-related comorbidities compounded these issues. And the cost of being left behind, starting from research and even from the root of the studies all the way to the implementation in our clinics and the social biases, means that there is greater mortality and morbidity in women post-MI. This reached the headlines, I think, 2-3 years ago in ESC. Women are more likely to die from heart attack. Obviously, delayed diagnosis leads to worse outcomes and ultimately higher healthcare costs. And many studies from patient survivor groups have actually reported the emotional toll that women feel having been survivors. They often feel dismissed or unheard in clinical encounters from the start and in continuity. This is a study that actually also was from the same Accenture paper published 2-3 months ago that showed the worst outcomes because of delayed diagnosis in women. So I will conclude shortly by presenting one of my patients. She was asymptomatic and she was referred by our national healthcare system to the cardiology clinic. She was 62 years old because her general practitioner found that she had some ischemic changes on the ECG. Specifically, she had some T-wave inversions in the anterior leads, V1 to V6. On serial repeat ECGs, these persisted. They were non-specific and not dynamic. She had no classical symptoms of chest pain. Of note, she had dyslipidemia, suboptimally controlled with LDL of 3.8. Her home blood pressure showed a systolic blood pressure consistently between 120 and 130. In terms of her family history, of note, her father had passed away suddenly at the age of 40. So I offered her either a functional assessment or a CT coronary angiogram because it was important that her family history was significant. She had some risk factors. She was postmenopausal, although she did not have pregnancy-induced hypertension. After a discussion, she chose to do a treadmill echocardiogram because she was not so keen to have any IV plug setting. The stress echo was negative for ischemia, but the stress ECG was quite positive, showing ST depression in 2,3 AVF, horizontal ST depressions at peak, 2 mm that persisted into recovery, although she was largely breathless without any chest pain. So I took a further history from her, noting the functional assessment findings, and she's continued to dismiss her symptoms and said maybe she felt a little more tired when carrying her grandchild, and perhaps a little more breathless when carrying some packets of rice from the market home. Again, generally continued to say she felt generally well. But I was anxious, and we discussed the discordant findings, and I advised a more sensitive modality such as the CT coronary angiogram, to which she eventually agreed. And it actually showed this. We see that there is very calcified lesion in the LAD, but more importantly, there's high risk plaque across the proximal, mid, and distal RCA. You can see that on the right, non calcified plaque with positive remodeling. And this was what the diagnostic angiogram showed, significant disease in the RCA. Ultimately, it was decided that she would receive her stents because of her symptoms, which on table, she said actually she's been having a little bit more exertional symptoms, although a reasonable alternative could have been a trial of medical therapy, especially because this was non-left main disease. So, what are some of the takeaways from this 62-year-old seemingly asymptomatic patient of mine? I think as physicians, we need to have a high index of suspicion for coronary artery disease, especially in women when there are relevant findings such as ECG, presentations, gender specific risk factors such as pregnancy induced hypertension, positive family history. And when tests show discordant findings, we should look at it again and perhaps consider a more sensitive modality if the burden of risk favors that option. And of course, we would need to reinforce strict adherence to goal-directed treatment therapy, reinforce this need and not shy away from the doses of medication it would take to reach the target LDL, knowing based on multiple sources of literature that women tend to be undertreated from the medication adherence perspective all the way to the revascularization. So what really needs to change is it starts from research. I think Dr. Beale presented beautiful research to us, and we need more of that. Inclusive research designed with sex disaggregated data. The providers, doctors need education on gender-specific presentations, especially when it comes to coronary artery disease. And women don't always present with typical chest pain. We need policy level changes to mandate equity in funding and trial enrollment. And where more mature, when the ecosystem is more mature research-wise, we should also reinforce sex-specific risk calculators and diagnostic algorithms, and of course, tailored prevention strategies with calibrated risk when it comes to detecting coronary artery disease in women. And moving ahead in an era of AI, generative AI included, and precision medicine, we would be in a better position to deal with big data sets and perhaps tease out the differences in gender to allow us to tailor gender-specific risk prediction. We would want to engage in awareness campaigns targeting both clinicians and the public, and this initiative today that we are invited to participate in, I felt strongly about, and many thanks to the organizers for inviting me to be part of this campaign for women, to advocate for them. And we would like to build interdisciplinary collaborations and cross-border collaborations between specialists and between healthcare ecosystems to continue to uplift women and give them the spotlight that they deserve to overcome this silent epidemic. And with that, I thank you for your time and would like to invite any questions.
Thank you, Dr. Natalie. Thank you, Dr. Natalie. I think you very clearly highlighted the deficiencies we have when it comes to women and cardiovascular disease. We have a few of our other expert panelists have joined us. Professor Bilal Muhyiddin and Professor Fawad Farooq are with us now. I'll move forward and maybe we can have comments after the next presentation from our panelists for Dr. Natalie's presentation. I'd now like to invite Dr. Samra. Dr. Samra Haq has joined us from the Punjab Institute of Cardiology, where she is an assistant professor, and she will be talking about the effect of serum lipid profile on the risk of breast cancer.
Bismillahirrahmanirrahim. Today, topic of my discussion is effect of serum lipid profile on breast cancer. So this is an overview of my presentation, that is a little bit background on breast cancer, then comes what is a serum lipid profile, then how lipids might affect cancer risk and progression, and then comes key findings from research, and finally what are the clinical and therapeutic implications. Breast cancer is a global concern, that is most common cancer among women globally. According to data, it is a malignant condition that is affecting about 2.1 million women worldwide, and the incidence is rising, especially in developing countries nowadays. And what are the risk factors for breast cancer? Genetic, that is some mutations in the genes like BRCA1 and 2, they are inherited and they carry the risk of CA breast in families. And then comes hormonal. In hormonal, early menarche, that is before the age of 12, late menopause after age of 55 years, nulliparity are the first child after the age of 30 years, and then not breastfeeding. They also increase the risk of breast cancer. Then comes environmental factors, that is exposure to radiation, especially chest area that is exposed to radiation, that also increases the risk of breast cancer, and certain chemicals. Then comes lifestyle factors, that is obesity, overweight, physical inactivity, increased dietary fats, then smoking, then lack of or short duration of breastfeeding, and again low parity. These all carry an increased risk of breast cancer. And then systemic diseases like hypertension and diabetes that needs to be addressed. Okay. Then what is understanding the serum lipid profile? That is, total cholesterol is a structural component of cell membrane. And LDL, that is low density lipoprotein, delivers cholesterol to the cells, while HDL, high density lipoprotein, that removes excess cholesterol. And triglycerides, these are energy storage molecules that are linked to metabolic syndrome. And what are the possible mechanisms linking lipids to cancer? Cholesterol as a precursor to estrogen synthesis that influences estrogen receptor responsive tumors. And LDL promotes cell proliferation and inhibits apoptosis, while HDL's antioxidant properties may be protective, as is in ischemic heart disease. High triglycerides may promote inflammation and insulin resistance. Changes in concentration of serum lipids in patients with breast cancer will result in an increased production of tumor necrosis factor alpha. That in turn leads to inhibition of adipose lipoprotein lipase activity by insulin. And finally, these changes will impair the catabolism of LDL cholesterol. So besides the proliferating cells, such as cancer cells, have increased requirement of cholesterol and facilitate lipid biosynthesis and metabolism, that will finally lead to increased serum cholesterol levels in patients with breast cancer. So what does scientific evidence say? Lipid levels and risk. Meta-analyses suggest high cholesterol is linked to increased breast cancer risk, while low HDL levels correlated with poor prognosis. That is same as in ischemic heart disease. While elevated triglycerides are associated with larger tumor size and lymph node involvement. However, some studies show no clear link up till now. Estrogen receptor and progesterone receptor responsive tumors are more responsive to changes in lipid environment, while human epidermal growth factor receptor and triple negative breast cancer show different lipid metabolic activity. It depends upon different types of breast cancer, while lipidomic profiling helps to distinguish tumor aggressiveness. So, what does a statin can do in CA breast? That is a promising avenue that statins lower cholesterol by inhibiting HMG-CoA reductase. While preclinical studies, statins reduced tumor growth and metastasis. While clinical trials underway to test statins as adjunctive therapy, and potential anti-inflammatory and immunomodulatory effects of statin also have an effect. And what are the therapeutic and diagnostic implications? Lipid profile is used as a prognostic biomarker, while integration into breast cancer risk assessment tools. So lipid lowering drugs are used as a part of treatment plans now. So personalized medicine based on metabolic profiling is needed. These are few researches that shows a link with breast cancer. The association of serum lipid levels with breast cancer risk among women with breast cancer at Field Harvard Comprehensive Specialized Hospital, Northwest Ethiopia, that was published in Breast Cancer Targets and Therapy volume in 2020, that concluded the overall prevalence of dyslipidemia was high in breast cancer patients. Again, age at first parity, alcohol consumption, and BMI were significantly associated with low serum HDL cholesterol levels. And again, low HDL cholesterol levels carries worse prognosis. And another article was evaluation of the blood lipid profile pattern in female breast cancer patients in Jordan, that was published in 2024. That was concluded as this study showed a clear correlation between increased BMI, altered lipid profiles, and an increasing risk of breast cancer in women living in Jordan. And this was a comparison of serum lipid profiles between normal controls and breast cancer patients that again showed a high level of triglycerides, low density lipoprotein, and low level of HDL in cancer patients. So all these results, they suggest that increased serum lipid profile may associate with breast cancer risk in women. So further studies to group important factors including cancer stages, types of cancer, parity, and menopausal status that may affect to lipid profiles in breast cancer patients, along with an investigation of new lipid profiles to clarify most lipid factors that may involve in breast cancer development, they are needed. So these are the challenges in research that need for standardized lipid measurement in studies, variability in populations and methods, confounding factors like diet, exercise, body weight, and genetics, and limited international studies establishing causality. So I conclude my presentation over here that lipid metabolism plays a complex role in breast cancer, and serum lipid profile could aid in risk prediction and treatment. So multidisciplinary research is key to future breakthroughs. Thank you very much.
Thank you, Dr. Samra, and thank you for being such a good sport about timekeeping. I appreciate it. Dr. Natalie, are you still with us online? Is Dr. Natalie still with us online?
Yes,
okay,
I am.
so as promised, we have caught up a little bit. I would like to invite a couple of comments and questions from our panelists or audience. for Dr. Natalie.
बिलाल बोलना तूने कि नहीं?
We'll do the remaining comments
Okay.
and questions at the end of the session.
Just a short comment. I've heard 2 lectures by foreign speakers, both on heart failure with preserved ejection fraction and the gender. And the topics were why the women are left behind. It is so very unfortunate that this has become a cultural aspect as well. And you know, we keep complaining that women were underrepresented, under-recruited, under-investigated. And after hearing all that, I wonder how many of you know that in mid to late 90s, a big study of very reasonable size was conducted under the name of WISE. That meant Women Ischemic Syndrome Evaluation. And they came up with recommendations that women should know their numbers, they should not keep quiet about their disease, they should educate themselves, and they should go for regular checkup. Thinking retrospectively, when this GO-RED came into being, I consider GO-RED is the philosophical interpretation of the scientific study WISE. That's all I wanted to say.
Good morning or good evening, Natalie, and all the speakers. And this is Professor Bilal Muhyiddin. Sorry I joined in a bit late, but I heard a little bit of your talk, and I'd like your comment on a simple question. So are lady hormones protective, or they are not? We have this discussion on cholesterol going on. We have this discussion on, despite everything, ladies having all the problems. That, you know, it was considered that they are hormone protected. I'm especially asking this question because yesterday a lady walked into my office and she has triple vessel disease, ended up with stentings, and she was in a foreign land at that time. They did not do one of those vessels, has left them for the further evaluation. And she has normal cycles and everything. So my only question basically is, are your hormones protective, or is still testosterone the best? Question mark. Let's see.
Testosterone को कहाँ से लेते हैं?
I think I wouldn't phrase it as estrogen versus testosterone because, as we know, all genders have both hormones. I would say that there is a lot of discussion, and I think I'm not sure if we are going to bring in hormone replacement therapy, but that's a separate discussion. I think we know that for women, estrogen has been generally protective from a coronary artery perspective because we do see an uptick in coronary artery disease that far exceeds the pace when it comes to age and age-matched men when women are 10 years from the time that they've menopause. Now, whether or not there is a role for hormone replacement therapy in the prevention of coronary artery disease, this remains to be seen. It's not well studied, but modern hormonal replacement therapy for the management of pre, peri, and postmenopause is increasingly well studied and advocated. Of course, there are certain groups that have to be excluded from HRT, and these include women with specific types of gene-mediated breast cancers. Our speaker just prior to me had presented this. Second, women who have had a history of pulmonary embolism or prothrombotic state are excluded from hormone replacement therapy. But short of that, it has been increasingly utilized given the modern proportion of the estrogen quantification for the purposes of bone health preservation, as well as mediation of perimenopausal symptoms like brain fog and mood dysregulation. Specific to coronary artery disease and heart health, I think research is still ongoing, and I would welcome anyone with any insights as to that. So going back to the question, estrogen versus testosterone, there is a role for both. I think specific to women, for various reasons, perhaps the fact that we bear the burden of reproduction, we are protected by our hormones, but that protection is lifted 10 years post-menopause, where our coronary artery disease accelerates at a pace that outpaces age-matched men. As such, we need to be vigilant. Our thresholds for sensitivity in terms of coronary artery disease detection and advocacy for medication adherence and lifestyle modification must continue stringently.
Thank you. That was like watching a tennis match. That was a beautiful answer. Thank you very much. We will move on to our next international speaker. Dr. Sitara has joined us. Dr. Sitara Khan is a consultant cardiologist from Frimley Park Hospital and Heatherwood Hospital, London. She will be talking about hypertensive disorders in pregnancy, which increase subsequent risk of ischemic CVD events. I know she's running from one commitment to another. So thank you for joining us, Dr. Sitara. Okay, I think there's some technical issue, so I'll go ahead with my presentation, which is about stress. And my name is Dr. Sayyida Saira Bukhari, and I'll be talking about stress and the heart, mind-body approaches for prevention, spotlight on women. Can you see my slides yet? No.
Bilal? अगली दफा तू सवाल पूछेगा ना, खड़े होके पूछना, कहना मैंने रेड ड्रेस तो नहीं पहना, सिर्फ जूते पहन के आया हूँ.
कुछ तो पहन.
हाँ, ये थोड़ा अपना इंटरेस्ट जाहिर करने के लिए.
Thank you. So I'll try to do this as quickly as possible in the interest of time. So this is the roadmap for my presentation. I'll be talking about the role of stress in CVD, stress, women and CVD, the role of physicians in this paradigm, and individual level therapies for stress and cardiovascular disease. So what is the premise? We know that Interheart found that stress and stressful events, chronic stress, stressful life events, and depression are a strong predictor of MI with an odds ratio of 2.67, and that neuromodulatory strategies targeting the brain and heart can actually have the potential to provide a new kind of therapy for cardiovascular disease. We know that women have this long life of reproductive milestones, and as rightly pointed out by our previous speakers, protective effects of estrogen are often mitigated by pregnancy milestones and preparing menopause and menopause. And acute psychosocial events can cause acute coronary events in women, and unless there is resolution and adaptation, which does not always occur, and the pro-inflammatory state occurs in women. When we talk about the biological effects of psychosocial stress, there is an increase in inflammation, there's an activation of the neuroendocrine axis with increase in cortisol, and there are also increase in autonomic function with an increased sympathetic nervous system activity. So when we talk about women specifically, we know that psychosocial stress in women is multifactorial, and there are some very women-specific elements to it. For example, socioeconomic disadvantage, childhood adversity, race, ethnicity, intimate partner violence, marital stress, caregiver stress, and the reproductive milestones. All of these are very peculiar to women and can cause a lot of psychosocial stress. This leads to maladaptive responses, which are mediated through two mechanisms, biological and behavioral pathways. Biological pathways include vascular dysfunction, immune dysfunction, and inflammation. And behavioral pathways include disengagement, non-adherence, physical inactivity, increased adiposity, dietary indiscretion, sleep disturbances, and smoking, etc. And all of these predispose to cardiovascular disease. When we talk about cardiovascular diseases which are associated with stress and are more prevalent in women, we talk about mental stress-induced myocardial ischemia, which is more often seen in a younger age, and is because of microvascular reactivity. Then we have SCAD, which also has a female preponderance and is seen in young to middle-aged women who are perimenopausal. We also see Takotsubo stress-induced cardiomyopathy, again seen in mostly postmenopausal women, again due to catecholamine storm. INOCA, which is again seen in older women, seen more with smoking and metabolic risk factors, as well as mental health disorders. We have MINOCA, which occurs at a younger age, and is caused by platelet disorders, psychological stress, inflammatory disease, etc., as well as HepPep, on which we had a master class already. So when we talk about women, we need to do preventive health care, we should talk about psychosocial stress, and work to get this incorporated into guidelines. And further studies are also required in this domain. When we talk about management of psychosocial stress in women, we need to take into account individual level interventions as well as community level interventions. When we talk about individual level interventions, we can talk about cognitive behavioral therapy, mindfulness, biofeedback techniques, stress management, lifestyle coaches, stress education, interpersonal therapy, sleep hygiene, preventive health care. When we talk about community and policy level interventions, we can talk about neighborhood coalitions, community support networks, task shifting from physicians to community health workers. Let's get women the kind of people they actually want to talk about. Geomapping, identifying vulnerable populations and directing resources towards them, and also looking at housing, socioeconomic status, food security, etc., as well as general security, which can cause increased stress in women as well. When we talk about binary body and mind interventions, how do they work? Basically, they work on the hypothalamic pituitary axis, they work on the central nervous system, and they work on the autonomic system. And through this, they decrease inflammation, decrease sympathetic drive, and cause decreased cardiovascular disease in women. How can physicians help? So there are 4 words here: optimism, positive affect, and life satisfaction, gratitude, and leveraging personal strengths. We should ask them things like, how do you expect things will work for you in the future? And you can reinforce them. You can tell them, I have seen that you have handled the situation very well. We can talk about positive affect. We can talk about meaningful methods in which they can improve their quality of life. We can talk about gratitude. Some women have very difficult lives. We can talk about what did go well. For example, they successfully managed to recover from this disease. And we need to leverage personal strengths. They may be good at something, and let's try to get them involved in those activities and improve their psychological well-being. Some practical approaches can include addressing these issues in the clinical cardiology appointment, doing cardiac prevention and rehab programs, community resources, and psychiatry and behavioral health clinicians as well. When we talk about, then there is also talk about the cardiovascular psychologist who can also help and integrate in the current cardiology clinic and help women with their disease. These are some individual therapies including CBT, biofeedback, stress education, lifestyle coach, sleep hygiene education, etc. And with this, I conclude my presentation, and I would like to send you home with these take-homes, that psychosocial stress is a significant contributor to CVD, especially in women who are vulnerable to more psychosocial stresses. A multi-pronged approach is required, and of course, most importantly, clinical trials need to consider this factor when they talk about cardiovascular disease and addresses it well. Thank you very much. Thank you, madam. Yes. Maybe at the end, madam, if you don't mind.
Who is the next speaker?
Dr. Khalda, and we have Dr. Sitara. Dr. Sitara, she's our international speaker. I don't want to make her wait. Okay. Thank you so much, madam. So Dr. Sitara Khan is joining us from London. She's a consultant cardiologist at Frimley Park Hospital and Heatherwood Hospital, and she will talk about hypertensive disorders in pregnancy, which increase subsequent ischemic CVD disease events. Over to you, Dr. Sitara.
Thank you very much for that introduction, and thank you for the lovely talk that you just gave. Assalamu alaikum, everyone. I will just share my presentation. Okay, hopefully you can all see the slides all right. So the topic that I have been given, as was mentioned, is hypertensive disorders in pregnancy.
Dr. Sitara, we can't see
you can't see them? Sorry, I will try sharing again.
Yes, we can see them now. You just need to put them on slideshow.
Okay, great, thank you. So hypertensive disorders in pregnancy increase the risk of subsequent ischemic cardiovascular disease events. This is something which I'm sure the audience will have a fair idea of already, but just to provide you with an overview of what I will be talking about. Um, so if there is just a way to minimize myself so that I can see all of the text, bear with me. So what do we mean by hypertensive disorders in pregnancy? What impact do they have on women? Can I just check that everyone can see all of the text on the slide, that it's not being overlaid
Yes, we can.
by my... Okay, fantastic. So what impact do they have for women's cardiovascular health? And can they all just be explained by the mechanism of hypertension causing end organ damage? And then finally, what can be done to reduce the risk? So the definition and impact of hypertensive disorders of pregnancy. uh, The definition, there are various conditions that are included in HDP, either pre-existing hypertension going into pregnancy, gestational hypertension that develops during pregnancy, or preeclampsia, with the latter being defined as new onset hypertension associated with end organ damage after the 20th week of pregnancy. Together, these hypertensive disorders affect nearly 10% of pregnancies and, importantly, account for about 14% of maternal deaths worldwide. And they are the second leading cause of maternal mortality worldwide, and a major cause of neonatal and maternal morbidity, the highest cause of maternal mortality worldwide being hemorrhage. Their impact on cardiovascular disease, I've decided to group it according to the subtype of hypertensive disorder. So if we start with gestational hypertension, women with that have a 2 to 4-fold increased risk of developing hypertension in later life, but they do also have at least a 1.5 times higher risk of having a major adverse cardiovascular event and a possibly increased risk of stroke. Women with chronic hypertension, unsurprisingly, will have an increased risk of stroke, cardiovascular events, atherosclerosis, and peripheral vascular disease. But that we know in any case that hypertension is a risk factor for all of those conditions. Women with preeclampsia, as well as having an increased risk of developing hypertension later in life, they do have a risk of stroke, which is 2 to 3-fold higher, and up to a 3-fold higher risk of a major adverse cardiovascular event, and increased mortality by 2-fold, which is not insignificant. The risk seems to be highest in women who develop preeclampsia before 37 weeks gestation, and those women in particular have an approximately 8-fold increased risk of ischemic heart disease. So the degree of increased cardiovascular risk does correlate with the severity of the hypertension, with mild hypertension being associated with a 2-fold increased risk, whereas on the other end of the spectrum, severe hypertension is associated with a greater than 5-fold increased risk. It's not known whether preeclampsia itself is the cause of the increased risk or whether it's actually caused by an underlying disorder. This particular meta-analysis and systematic review is well worth pointing out. This is, I believe, the 6th meta-analysis on this subject in terms of the impact of hypertensive disorders of pregnancy on cardiovascular risk. It's the 6th one, it's the most recent one, and it is the biggest one as well, which is why I've chosen to focus on it for a few moments in this talk. So the authors looked at 73 studies involving more than 13 million women, so a huge number. The majority of these studies were cohort studies, with just 7 being case control. And they were published over a quarter of a century, literally a 25-year period between 1995 and 2019. But the majority were published in the more recent decade of that time period. Majority were conducted in Europe, and then 20% in North America, 14% in Asia, just to highlight that. And the follow-up period ranged up to 4 decades out, depending on the study. Importantly, 26% of the studies did not adjust for any confounder when they were estimating the risk of cardiovascular disease, but the remaining studies did attempt to match for age, smoking, and other potential confounders. So the long-term relative risks, if we just look at the breakdown according to the type of cardiovascular disease from this very large meta-analysis. So 1.8 for cardiovascular disease, similar 1.8 for mortality related to cardiovascular disease, 1.7 for coronary artery disease, nearly 3 for heart failure, just above 3 for hypertension, and 1.6 for peripheral vascular disease. And an interesting point, the risk estimate of cardiovascular disease-related mortality was higher in studies conducted in Asia than in those conducted in Europe. And this just shows that increased relative risk of cardiovascular mortality in a scatter plot format. Really, that's quite striking. And the confidence intervals you can see for all of those studies, apart from 3 of them, the confidence interval is quite convincingly towards a higher relative risk. But the limitations of data, whether it's from this meta-analysis or from other studies, is how is something like coronary artery disease defined? Is it on the basis of a minor troponin rise, which was due to something else? Is it on the basis of non-specific T-wave changes that then resolved? Is it on the basis of plaque, which was found on a CT coronary angiogram, which is non-flow limiting? It's very difficult to establish how that is defined in any of these studies. There are significant unmeasured confounding factors that can contribute to the association or apparent association between hypertensive disorders of pregnancy and cardiovascular disease. Only a few studies adequately controlled all the cardiac risk factors, including, BMI and hypercholesterolemia and family history of coronary disease. The duration of follow-up as well in several of the studies was just not long enough to capture all cardiovascular events. And of course, this meta-analysis was conducted over a quarter of a century, during which time various advances would have developed in treatments for heart failure, coronary artery disease, valvular disease, etc. Can this increased risk be explained just by hypertension alone? I'm afraid it can't. Studies show that only up to 2/3 of women with cardiovascular disease after hypertensive disorders of pregnancy have persisting hypertension. So it can't all, this phenomenon cannot all just be explained by hypertension. And there's this concept now of accelerated cardiovascular aging, where there's actually a greater prevalence of atherosclerosis in women in their middle age, 45 to 55 years, with prior history of preeclampsia, for example. There are differences in arterial stiffness in these women compared to hypertensive women during pregnancy, and these differences persist beyond a decade after they've had their child. There's an increased risk of premature valvular disease in the form of aortic stenosis, mitral regurgitation. So there is this concept of accelerated cardiovascular aging. And this really just illustrates that from a JACC paper, where it's not just the coronaries that are affected in these women, but the pump as well, the diastolic and systolic function of the left ventricle, the valves, aortic stenosis, mitral regurgitation. In red, you can see the HDP women, and in blue, the non-HDP women. Heart failure risk persists for at least a decade postpartum. There's a strong association between preeclampsia, eclampsia, and heart failure, both with preserved ejection fraction and reduced ejection fraction, even after other heart failure risk factors have been adjusted for, including chronic hypertension and diabetes. Women with preeclampsia, eclampsia previously remain at risk for long-term heart failure, even after the physiological changes of pregnancy have long resolved. This risk persists for a decade plus, as I'll show you in a graph. Chronic hypertension and diabetes have been identified as independent risk factors for heart failure with preserved ejection fraction. and they're found to be more common among women developing this than those developing heart failure with reduced ejection fraction. And here is a graphical representation from this JACC paper of the risk of heart failure hospitalization in women who've previously had preeclampsia and eclampsia. If I can please just draw your attention to the graphs on the right side, which actually show the years since delivery, and it's going out to 10 years, they continue to have an increased risk of heart failure, both preserved ejection fraction and reduced ejection fraction.
Dr. Sitara, could I ask you to conclude, please? Thank you.
Yeah, it's my last two slides now. So what can we do to help reduce risk? Plenty. The Federation, International Federation of Gynecology and Obstetrics say that women should be screened where appropriate. They should have their blood pressure taken. They should be given prophylaxis with low-dose aspirin. If they're high risk, it should be started before 16 weeks of gestation. They should be advised on healthy diet and also on physical activity. All of these things can reduce the risk of hypertensive disorders of pregnancy. This reiterates that message from the American journal JACC. So the summary is that hypertensive disorders of pregnancy can present in 10% of all pregnancy and are the second leading cause of maternal mortality globally. They are associated with a twofold increased risk of cardiovascular mortality. And in addition to causing traditional vascular diseases, they also increase the risk of heart failure and valvular disease and atrial fibrillation. And the increased risk of future heart failure does persist for at least a decade, but there are things we can do to help as physicians, including screening, dietary and lifestyle modifications, and low-dose aspirin. Thank you.
Thank you, Dr. Sitara. That was a wonderful presentation. I would like to invite our chairperson for Go Red for Women, Professor Khalda Sumro, for her presentation. We will take a couple of comments before we do that. Could I take some comments from the panelists, please? And could I please invite Professor Harun Babar on stage to chair this session, please?
I wanted to make a comment after your presentation.
Thank you, madam.
Psychosomatic stress and heart, because the topic is very close to my heart, and previous speakers have been talking about gender differences. And my heart aches to narrate that we, unfortunately, are the residents of South Asia, 23% of world's population, and mashallah, the characteristics are दुनिया का गरीब तरीन, जाहिल तरीन, and above all, least gender sensitive. I mean, your topic, your presentation reminds me of a young patient of mine who was only 19. I will just take a couple of minutes. And I went for my ward round and I saw a lady, kala kuba, burqa sa pehna hua. My staff was really scared of me. They had discharged her. No, what happened? ECG look. नहीं मैडम, इसकी कल शादी थी और वो करना नहीं चाहती थी, ये प्रिटेंड करके गाड़ी में फेंट हो गई, मदर ब्रॉट हर हियर. I said no. I had a look at ECG. It was suspicious. I took her to echo room. मैंने कुंडी लगा ली उधर से, उसका बुर्का उतारा. I said मेरे पर्स में कुरान होता है, मुझे तुम कुरान पे हाथ रख के बताओ क्या हुआ. She started crying. She said, मैडम मेरी 19 साल उम्र है, मेरा एक भाई है, वो बहुत नालायक है, उसे लाहौर पढ़ने को भेजा है और मुझे 8th के बाद घर बिठा लिया. रो रो के मेरा बुरा हाल. और एक हफ्ता पहले my mother told me that she was being married off to a man who was 55 and had never seen the school. She was going from Pindi to Lahore और आधे रास्ते में she must have had an attack और माँ ने थप्पड़ मारा कि pretend कर रही है. जब वो बिल्कुल collapse कर गई, she was brought to the hospital. I did her echo and believe me, my reflexes are very brisk. Probe मेरे हाथ से गिर गया. 80% of LV had gone. Strictly instruction ये नहीं. अगले दिन मैं आई, उसको डिस्चार्ज करा के ले गए थे. मैं फॉलो करती हूँ, 1 महीने बाद पता चला her body was brought to this place from her in-laws. सो कुड़ना उसने खुद बताया, मैडम मेरा भाई आता था, मेरी अम्मी के खाने पकाओ, इसके कपड़े धो, और मैं छुप छुप के गांव की लड़कियों से मिल के मैंने 8th क्लास तक पढ़ा. I want to, so this stress, and this is not the story of that particular patient, this happens very often. हर जगह I hope there was a minority, because unfortunately we the Muslims were made to live with that minority before partition, जहाँ पे औरतों को दूसरे दर्जे का शहरी समझा जाता था. तो आपने सारे वो बुरे रिवाज वहाँ से ले लिए और अपने हजूर सल्लल्लाहु अलैहि वसल्लम को, तुम्हारे बेहतरीन सलूक का हकदार कौन है, तुम्हारी माँ, तो फर्स्ट टाइम योर फादर. सो इसमें रिलीजियस सोच, मुझे वो लड़की आधी रात को भी कभी मेरी आँख खुल जाती है. And there are many more, but she was the youngest that I ever came across with a massive heart attack. And where were her hormones? Hormones were very well there, but it is the stress and the microvasculature that beats your hormones. Thank you.
Thank you, madam. Yes, Dr. Bilal, you'd like to say something?
Right. Thank you. One comes across all kinds of patients, and I'm reminded of a patient with Cushing syndrome, young lady having stresses, etc., and getting a blown out her heart. But anyway, that's a different thing as far as, and Professor Sahaba has already pointed out a couple of things very important. Basically, my question is focused to Sitara. And Sitara, this is Bilal Muhyiddin. It's really nice listening to you again. I've had the privilege before also to meet you and discuss. So I wonder if you can hear me. Can you hear me?
Yes, I can. Assalamu alaikum.
Assalamu alaikum once again. Okay, so the big question is, so when we talk about the ladies, my question is about the hormones today. And we talk about how the hormones affect the ladies during pregnancy. Then we talk about, also the basic fact is, usually the ladies live about 10 years longer. That's the way roughly the profile is. In Pakistan, for men it is about 65, for ladies it's about 75, and I'm sure something like that for UK also. So on one side, we talk about a normal protective mechanism of hormones that is provided. Then on the other hand, we are talking about the fact that those who unfortunately have this overlay of the hormones coming in, and is it these hormones which is causing all of that hypertension, or it is something else which is causing that hypertension, which is then responsible for all the other problems that the ladies have during pregnancy? And then because this factor never goes away, and as you have pointed out, but then having said that, one comes across ladies who have been hypertensive and yet they lead a reasonable life. But unfortunately, many of them have other comorbidities also. So then you have a discussion. So my basic question is that whenever you have these hormones causing hypertension or problems, so is it at any level, if you do these studies, if you do an analysis of these hormones while they are expecting, is there a cutoff which may guide us to say that, look, you are one of those who are going to end up in a problem? Or then if we can find that hormonal level, is there a way to control those hormones? Any idea on that?
Yeah, I think that's an excellent point. And there are a couple of theories as to why women who develop hypertension or a hypertensive disorder in pregnancy do have this prevailing long-lasting risk, even if they are not actually hypertensive later on in life, although many of them do become hypertensive. So one of the theories is that pregnancy itself, it is a stress test, a very big stress test on the maternal circulation, on the testing the heart to its limit in terms of the changes in peripheral vascular resistance, cardiac output, and that stress test in some women unmasks endothelial dysfunction and the propensity for abnormal vascular responses and vascular remodeling in later life. So when teams such as the one who looked at the arterial stiffness index they found that the stiffness index of women was increased in their arteries more than a decade after they'd given birth. And that is a marker of vascular health, or should I say vascular ill health. So that's one theory, that the pregnancy itself resembles a big stress test. Then the theory about this other factor, which, as you say, may well be a hormone, this other factor that has not yet been characterized and isolated, that is present in pregnancy, is a very fascinating one, because really we came to know for quite a few decades after describing peripartum cardiomyopathy, then Karen de Slewa in South Africa, initially with her mice models and then translating to human studies, she and others helped actually find that one of the mechanisms of peripartum cardiomyopathy was the cleaved prolactin. And you know, so that's fascinating. And now we're using bromocriptine with success in women with peripartum cardiomyopathy. So I completely agree, Professor, that there may well be an as yet unrecognized hormone, and it would certainly be worth keeping the samples of women who have these hypertensive disorders of pregnancy to try and identify what that is. At present, though, what is in our gift to do, by the grace of Allah, is absolutely to address lifestyle factors which are already known as culprits and which will have an impact on general health as well as vascular health, such as diet, exercise, blood pressure control, cholesterol control. These are in our gift to give at this point. We have the knowledge to address those at least.
Thank you. So, but my point still remains. So, a person who is hypertensive becomes hypertensive and during the first pregnancy, and once again you have used all the medication. So, should this lady become her next pregnancy, which is also chances are there, some of them become hypertensive either in the second or the third, but there are unfortunately few who get it early. Now, since you are very well aware of our cultural problems over here about gender-specific desires of birth, so a person who has hypertension, should pregnancy be told to her that is contraindicated?
That's an excellent point. So it is not viewed in the literature and in the guidelines. It is not viewed in the same category as peripartum cardiomyopathy in that respect, where with peripartum cardiomyopathy, even within that, as you're aware, there is a spectrum of severity. But if someone has had a severe peripartum cardiomyopathy, then we, even to this day and age in the UK, advise absolutely against future pregnancies. For the ones with the milder versions, then we will involve the obstetric team, pre-pregnancy counselling, careful monitoring during pregnancy and in the 5 to 6 months afterwards. These HDPs are not deemed to be in that category where future pregnancies should be against medical advice, but initiating that low-dose aspirin before the 16th week of gestation, it has been shown to be beneficial. So that our obstetricians have definitely adopted, that low-dose aspirin. Of course, it is down to the patient's motivation, how much she takes on advice about diet and exercise. But one thing I found as a British Asian doctor is that when you have someone from Asian backgrounds, they do listen more to the Asian doctors because they feel that there's that relatability. We appreciate what their diet is like, what the Asian food is typically like. If they have a Caucasian doctor or nurse or midwife trying to engage with them and not really having that cultural understanding, then the engagement is less.
Thank you. Sir, Professor Harun Babar, with your permission.
Yeah, thank you very much for inviting me here. First of all, I would like to thank Professor Khalda Samro and of course Professor Bandishah for arranging this Go Red for Women session, in which we have come across some very interesting presentations, especially one presented by Dr. Samra about the cholesterol link with the breast CA. There have been many studies which prove otherwise. Like many studies, if you go around them, they claim that it is an inverse relationship. And of course, there are a lot of studies which show that some of the malignancies are related to high cholesterol. But this metabolism of cholesterol and the malignancies, of course, is very intricate, and it is related, because I think there might be an element of inflammation in that, and there might be an element of many other processes going on at the same time, like interleukin and all those being involved in this process. So coming back to hypertension, which Professor Bilal was talking about, well, hypertension, especially essential hypertension, is a well-known risk factor for ischemic heart disease and cardiovascular disease, even disease of the nervous system and wherever the vessels are. And nowadays it is called a syndrome as well. And a syndrome which has a basis of different etiologies like inflammation. It is one of the syndrome which carries out inflammatory process in itself. And there are a lot of other processes going on at the same time, like the endothelium being involved all over the body. And that's how it damages the cardiovascular system and wherever the blood vessels are. And I think especially in our women, which we are focusing on in Pakistan, I think majority, like what we say, that 1/3 of the people know that they have hypertension, and 1/3 of the people are being treated for it, and 1/3 are only being adequately treated. I think in the female category it must be much less than that, because we don't have any large scale studies, especially in the female population. So we should concentrate more upon our female concentrations with respect to hypertension, and go on for the awareness programs and carry out further studies about it. Thank you very much.
So thank you very much. I think the lady of the evening is Professor Khalda Sumro. Without further ado, let's hear her talk about exploring the role of inflammation in CVD.
I think after the comments of Dr. Baba, I don't think my presentation will be much better than his comments. So we will start with the presentation without wasting time. The topic of my presentation is exploring the role of inflammation in cardiovascular disease risk in women. These are the highlights of the presentation. We know that approximately 1 in 3 women dies from the heart disease globally. 4-fold higher incidence is found in women than in general population. That is also a global data which is suggestive of. But unfortunately, we have more incidence in our South Asian countries like India, Pakistan, Bangladesh, Nepal, Sri Lanka, Bhutan, and Maldives. We know that there are advances in improving the morbidity and mortality from the CVD in women older than 55. But unfortunately, the improvement in younger women have been stagnant. Mechanism which is unclear and it lagged behind. These are the risk factors. Apart from the traditional cardiac risk factors, non-traditional risk factors, woman-specific risk factors, recent research is on the autoimmune disorders and emerging risk factors like cytokinase, interleukin. This paper was published recently in ACC journal that shows that triggers of the inflammatory response leading to atherosclerosis are traditional CV risk factors, which can lead to the low density lipoprotein, cholesterol, triglycerides, lipoproteins, and other risk factors. Then the chronic and acute mental stress, mostly it is from the non-traditional risk factors like urban areas, dual responsibility on the women leading to the mental stress and which can precipitate the autonomic nervous system and can give rise to the later on atherosclerotic changes and inflammation. Aging, bone marrow activation, clonal hematopoiesis, the behind mechanism which works in increasing the atherosclerosis and inflammation in the elderly women. Chronic autoimmune disease, rheumatoid arthritis, SLE, inflammatory bowel syndrome usually can lead to the inflammation and later on to the atherosclerotic heart disease. Amongst the other infections, chronic infection, acute infections, viral infections and tissue injury like myocardial infarction and non-healing skin ulcers. So that gives us the answer of Dr. Bilal Muhyiddin that lipid profile, when it is controlled, why not disease has been controlled? We can see the rising incidence of the infections, COVID recently, as well as the autoimmune diseases, LPA we will be talking later on. These are the risk factors which can give rise to the inflammation and later on the atherosclerotic heart disease. So, during the last 2 decades, clinical studies have shown that the atherosclerosis is a low-grade, sterile, chronic inflammatory disease in which autoimmune system has prominent role in the endothelial dysfunction, which usually results in increased permeability to the lipoproteins and their subendocardial endothelial accumulation, leukocyte recruitment and platelet activation. These are the end results. Recruited monocytes differentiate into the macrophages, which develops pro and anti-inflammatory properties. Inflammation also plays a part in vulnerable and stable plaques. So, ECM, collagen, elastin, lipoprotein particles accumulation in the wall of the artery, cytokinase giving rise to the MMP. So this MMPase catalyze the breakdown of interstitial collagen, which is responsible for the plaque instability and rupture. In women, coming to the age difference, we know that hormones protect the young woman, but despite of that, young women are suffering more and having more morbidity and mortality from the coronary artery disease and CVD. They have unique inflammatory response due to the hormonal influences on the CVD health, and the onset of CVD is almost 1 decade than the men in women because of the protective effect of the estrogen. But yet, in this age group, chronic inflammation is a key contributor to the development and progression of CVD in young age group by playing a role in endothelial dysfunction, plaque formation and thrombosis in this category. Aging, old age women. Old age women have aging is associated with somatic mutation in the bone marrow, and and the HCAS cells rise, which give rise to the all type of the blood cells, including immune cells, mutant clone of the leukocytes, and the altered immunological properties which may give rise to the atherosclerosis in the older woman. Not only this bone marrow mutation, there are other factors also, like a high LPA, small density lipoprotein, LDL. It is said that increased size of the LDL or normal LDL-C usually won't come out easily from the liver, from the receptors. Then the small size LDL particles, which will usually accumulate in the blood and can give rise to the atherosclerotic heart disease. They are more likely to enter the arterial wall due to their small size. Persistent residual CV risk. Despite optimal management of the traditional ASVD, risk factors may attribute to the high LPA level and chronic inflammation, especially in older women. So what is the synergistic effect along with the elevated level of LPA? This usually leads to the inflammatory process. Other biomarkers like high sensitivity C-reactive protein, interleukins, and along with this LPA can give rise to the more predictive power of the long-term CVD risk. Higher LPA was found in the South Asian women. We have talked about that there is a more incidence of the atherosclerotic heart disease in South Asian women. So we are coming to that point that the higher LPA was found in the South Asian women than men in all age groups, although the concentration and incidence was still lower than the quoted in the European literature. So higher level, not only they will give rise to the atherosclerosis and initial CVD or coronary artery disease, but this LPA can give rise to the instant restenosis with time as age advances, with a stronger association in the Asian population, especially women. It is also implicated in the heart valves. High LPA level was associated with the aortic valve, 82%, and mitral valve in 37% of the women. Involvement in the large vessel, thoracic, aortic vessel calcification, 36% occurs in the women with the, high LPA. We can see this patient was having the bioabsorbable stent due to the acute coronary syndrome. We can see that the inflammation, 1, 2, 3, 4 small dots behind that stent site later on with the OCT examination. So that is that in long runs LPA play a role in re-stenosis of the coronary artery diseases. We are coming towards the future. What is future? Genetic modification of the inflammation. The clonal hematopoiesis associated with the cardiovascular risk. The study was conducted in an inflammatory gene modifier scan for the chip associated with the CVD risk among 24,651 UK participants. The study found that the chip showed that CRI-CPR induced ASXI mutant murine macrophages has particularly heightened the inflammatory response to the agonism. associated with the increased DNA damage response, as well as increase in the 1L10 secretion, mirroring the CVD protective effect of 1L10 expression. So, studies supported the role of inflammation in chip associated with the CVD and provides evidence supported gene specific strategies to address the chip associated CVD risk. So these are the predictive values of the biomarker. Increased values of the biomarkers were found in this study, resulting in the high risk prediction of the coronary artery disease and stroke, aligned closely with the overall cardiovascular risk event. So what are the other factors, not only in South Asian countries? No. So what are the other factors? Systemic factors, mental stress. Yes, this is more common in South Asian countries. Emotional stress results in autonomic imbalance with increased sympathetic output and withdrawal of the parasympathetic tone, thus leading to the release of inflammatory cytokines. These directly impair the endothelial function and inhibiting the nitrous oxide synthesis and increasing the endothelial release, which can give rise to the atherosclerotic disease. This is the famous study which was suggestive of the increased body mass indexes in the South Asian countries. These are the dietary pattern. Higher pro-inflammatory potentials, red meat and all those animal fat containing the food are the higher pro-inflammatory potentials. We can see that higher inflammatory anti-inflammatory potential can be seen in the vegetables like goods. Immune system, that is another problem, because the atheroma progression is determined by the imbalance between the pro-inflammatory and anti-inflammatory activities of the immune cells, depending on the inflammatory environment, leading to the dynamic progression of the atherosclerotic lesions, which occurs through the phase of occasions and flares of the activity triggered by the systemic and regional inflammation. Vascular inflammation, one of the reasons for the atherosclerotic heart disease in women. But unfortunately, current guidelines from the American College of Cardiology and other European countries usually support only the risk factor and lifestyle modifications. There is gap in current and traditional guidelines because there is limited emphasis on the role of lipoprotein A and inflammation in risk assessment. No adequately address the unique CVD risk faced by the post-menopausal woman. Treatment. Role of the inflammation in atherosclerosis is confirmed in several studies by the effect of statin in reducing the risk, CVD risk, but it is unfortunately, despite of giving maximum dose of the statin, there is secondary prevention. For the secondary prevention, despite of that, there is usually residual risk of the CVD, as Dr. Bilal was asking from the foreign, our international speaker. Anti-inflammatory interventions, specifically blocking the cytokines pathways, reduce the further risk of myocardial infarction and stroke. Dr. Sara, so apart from the statin, we can try methotrexate has no impact on the this prevention, but of course, Kentos and colchicine tries prove the efficacy of these drugs in the So, the conclusion of my talk will be that recent epidemiology and clinical imaging studies support the hypothesis of systemic inflammatory and immune pathogenesis of atherosclerosis and its clinical implication. The combination of circulating and cellular imaging markers measured over the time may identify the individuals at a high risk of the CVD due to the inflammation, thus modulating the specific treatments, targeting the inflammation upstream and modulating the early phase of the atherosclerosis development may become effective therapeutic approach. And a more advanced understanding of the atherosclerosis inflammatory pathways may lead to the designing more specific treatments without compromising the immune system defense against the pathogens. Thank you.
Thank you, Madam. That was a very enlightening talk. And with this, we conclude our session. And I would request Dr. Khalda Sumro and our panelists to come and give the token of appreciation, the shields to the speakers. Madam, आप आ जाइए, आप लोग आइए, please. Madam, आप आइए, Dr. Nusrat. Welcome. इसको क्लैपिंग होनी चाहिए. Dr. Samra, please come up on stage to receive your token.
चेक कराया सलीम चेक कराया हाँ जी एडो को स्केलर दोबारा ऐड करें स्केलर दोबारा ऐड करें स्केलर दोबारा ऐड करें स्केलर दोबारा ऐड करें तेजी से
मॉडरेट भी करना होता है।
एक्सप्लेन करने जो हम नहीं कर रहे।
बिल्कुल सर, सॉफ्ट सर, इसमें इतना मटेरियल, मेरा दिल रो रहा था इसको स्पीड अप करने में।
तस्वीरें बना
सर आप ले लीजिए, सर प्रेजेंटेशन ले लीजिए आप।
से पढ़ूंगा।
सर जब मॉडरेट भी करना है, मैं तो डॉक्टर बंदिश शाह को देख रही थी, वो यूँ दिखा रहे थे मुझे घड़ी। थैंक यू सर, थैंक यू सर।
यार उधर होस्ट के लिए लेके आ स्लिप चेक नहीं आया, इससे कल प्लस माइनस करो, कुछ आ रहा है। आया रेजोल्यूशन शो कर रहे जी सर, आपके पास थ्रेडर ही है,
मैं उस सब चेक कर
सलीम आया, सलीम नहीं आया यार, केबल ठीक है, 100% केबल आज केबल हो गया, तो कैमरा उतार, कैमरे भी केबल पड़ रहा है। सिर्फ चेकर कैमरा है ना, जितने कैमरा से ना चेकर आया।
आप नेक्स्ट सेशन
एक सेकंड, एक सेकंड, ठीक अब चेकर होना है वो तो चेक करना, कैमरा चेक करना, कैमरा नहीं आ देखो उस कैमरे पे फ्रीज हो गया, कैमरा फ्रीज हो गया। दूसरी तरफ मुंह कर रहा था। ठहर जाएगा। हाँ आया, फेरू यार एचडी केबल लेके आ देख केबल आई है अच्छा आते आ रहे हैं ना बस ठीक है लॉगिन नहीं हो रहा पासवर्ड ना फेस लग गया है अब फट जाओ
Okay, Bismillahirrahmanirrahim. I'll request all the audience to please get seated. We are about to start the session. So I welcome you all to this second session of Midsummer Conference of Pakistan Cardiac Society, Updates Cardiology. And before starting session, I'll request the panel of experts to please have a seat at stage. I'll request Major General Retired Azhar Kiani sir, please have a seat as a panelist. I'll request Professor Mansoor Ahmed sir, please to join us as a panelist. And I'll request Dr. Khawar Kazmi as well. Sir, please join. I think we are already late, so before wasting any further time, I straight away hand over this podium to Professor Javed Akram, sir, and he'll be talking on a medical case-based approach to the management of rare cases. Sir.
Bismillahirrahmanirrahim and Assalamu alaikum. Certainly it's a great pleasure and honor for me to be talking amongst such an august gathering. We are either friends and families, the entire thing, and I'm very grateful to Akhtar who worked with me. Sorry, क्या कहना? क्या? As I said, and it's particularly very pleasant for me to have my dear class fellow Azhar Kiani chairing the session along with two brothers.
डिस्प्ले सेटिंग सर एक सेकंड दीजिएगा
ये तो लगाते ही हो जाता
नहीं वो लगा है केबल लगी है एक्सटेंडेड
नहीं उसे आ जाता होता है वो पूछता है मेरे रिंग चाहिए
वो आपका ना एक्सटेंडेड कहीं ऑफ है यहाँ से
कर
लैपटॉप
नहीं ये लो
एक्सटेंडेड मॉनिटर्स
देखें कहाँ है
मॉनिटर्स सर डिस्प्लेज यहाँ पे आइएगा when connected to TV refresh rate so यहाँ अगर क्लिक कीजिएगा एडवांस पे
मेरा नहीं ख्याल ये है
नहीं है
इसको ऑफ करके ऑन करो
सर देख लें
ये तो वैसे आ जाता होता है उसी वक्त ही
सर वो आपने लास्ट टाइम जहाँ पे लगाया होगा ना उन्होंने डिस्प्ले ऑफ कर दिया था
मेरा नहीं है या फिर यूएसबी में ले लेते हैं
हाँ यूएसबी में लेते हैं सर सी वाली नहीं है सर यूएसबी वाली ये तो शट डाउन भी नहीं हो रहा सर ये
उसको छोड़
देर से चल रहा है
नहीं वो चलता ही रहता है ये वाली है जुबैद अकरम बूरबन
जी सर
ये मैं पहले इधर कर दूं आप अपना लगा लीजिए नहीं पेस्ट करना है ना यार इधर वैसे कर लेता हूँ इसमें
वो नहीं इजाज़त नहीं दे रहा
क्यों
इसको सर डबल क्लिक करेंगे इसको यहाँ पे सर
पेस्ट हो नहीं ना
नहीं हुई सर
वो खींच के आ जाता है यार
सर ये बड़ी
वो
अलाउ ही नहीं कर रहा सर
क्या वजह ये कॉपी हो गया ये पता नहीं क्या वजह है तो कोई ऐसी वजह नहीं है मुझे दोबारा इसको
सर आपके पास व्हाट्सएप पे या ईमेल पे है
देख लेता हूँ अभी कर देता हूँ ईमेल आपको ये देखो यार बड़ा ही कर क्यों नहीं रहा
सर नहीं उसको अलाउ ही नहीं कर रहा
वजह
अगर आपके पास ईमेल पे या व्हाट्सएप पे है तो वो अगर दे दें हम
मैं ईमेल आपको कर दे रहा हूँ
सर
यहाँ पे वो वाईफाई
नेट भी नहीं चलता
ये ऑन कर
वाईफाई पे सर यहाँ पे इंटरनेट है नहीं
इसी गैस पर
किसी सर उसका पासवर्ड मेरा
नहीं वो भी उसकी ज़रूरत नहीं है टेलीफोन से हो जाता है अभी मैं करके आया हूँ ऊपर से ये
साइन व्हाट्सएप खुला हुआ आपका व्हाट्सएप
सर मैं ईमेल कर देता हूँ
सर ईमेल कर
हेलो स्लो है ज़रा, बताइएगा। एम
बिलाल
BILAL AM मीर 52
gmail.com।
ये ले हो गया।
सर एक मिनट दोबारा डिस्प्ले में जाएगा, डिस्प्ले सेटिंग में तब जाइए।
अच्छा सर एक सेकंड सर, लैपटॉप छोड़िए। नहीं दे रहा आप
डिफ़ॉल्ट है ना, तो उधर कर लें।
यहाँ पे सर सर्च कर लें।
क्या
सर यहाँ पे कीजिएगा।
क्या करें?
एक सेकंड, डिस्प्ले ऑप्शंस, डिस्प्ले प्रीसेट, डिस्प्ले सेटिंग्स, अरेंज मल्टीपल डिस्प्ले।
डबल क्लिक करो। इसको बंद करेंगे तो अब करें, किधर करूँ?
सर ये
जी बताएं।
सर ये नहीं खोल रहा, आपकी ऑप्शन नहीं खुल रही।
यार आप नेक्स्ट वाला करा लेना, तो उतनी देर में हम ये करें।
जी सर,
आप नेक्स्ट वाला करा लें।
नेक्स्ट वाला करवा लें उसमें। सर ये इधर
आप नेक्स्ट वाला करा लो, उसके बाद ये मुझे दे दें।
सर ये एक सेकंड मुझे दे दें, मैं ऐसे खेलूँगा।
नेक्स्ट स्पीकर की रेडी है, उनको इंटीमेट। Unfortunately, there are some technical error, and that can happens with machines. So we're moving on to our next talk, where Sajjad will be talking about human versus machine. Dr. Sajjad, please come forward and start your talk.
Is this working? ये कर रहे हैं? चल रहा है? बिस्मिल्लाहिर्रहमानिर्रहीम। रब्बि इश्रह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली। I brought my own laptop just in case this one doesn't work. So that's the way machines are for you. Now, what I'm being asked to do in about 10 to 12 minutes probably requires multiple webinars, but let's just get into the meat of things. So AI is different things for different people. AI is maybe just excellence in chess, or maybe it is just self-driving cars for some people, and maybe it is just Rufus who assists you in buying things from Amazon. But what is actually AI in scientific terms? So it is the ability of a computer system to perform tasks that typically require human level intelligence. Sorry. Is this, yeah, that's the day we're having. So what is actually intelligence? I'm just going to go through this briefly. It's the ability to perform reasoning, problem solving, and learning. And if a machine needs to reach human level intelligence, it will need to develop the faculties of perception, attention, planning, and memory. Now that's what a machine needs to have in order to become as intelligent as humans. So where are we right now? So these are the three kinds of AI that are currently present. So narrow AI is where we are. We haven't gone beyond this. So narrow AI simply means that a machine will perform a task that you ask it to perform, that you teach it to perform, program it to perform. The intelligence is still subnormal compared to humans. General AI would mean that it's equal to humans, and super AI would mean that it is beyond human intelligence. We are still at narrow AI. Now, I just want to go through some of the current stages of AI in healthcare. And when we look at AI, so what we have is AI algorithms in healthcare that help us with patient diagnosis, especially in terms of diagnostics, and then generate treatment plans. We know that the predictive analysis of AI significantly helped during the COVID pandemic, helping us to predict the course of the pandemic itself. And then now we can use virtual reality, augmented reality, and even mixed reality to generate simulations that can help us plan even coronary interventions. And I think these are some of the very common videos that you see online, especially when you're talking about bifurcation PCI. And when we look at when we look at cardiac imaging, it helps a lot in cardiac CT by telling us the different data points and quantitative analysis of the cardiac CT and the coronary arteries. We now have virtual health assistants that will talk to you, answer your FAQs, of course, and then generate a plan that is specifically for their particular patient. Now, what are the advantages of AI? The first is AI in image recognition. Now, this is very complex picture. Just forget about the whole thing and focus on the brain. So that's the occipital cortex. We are now creating artificial neural networks and convoluted neural networks based on deep learning algorithms. And they're all designed around the occipital network. So you first see a major picture, converge into a smaller picture, then move into the final details. And that's what these multiple layers actually show you. So this is what happens when you put an image into an AI algorithm. It picks up the cardiac CT, then it says this is the heart, then it says this is the coronary, this is the lumen, and this is the endothelium. So it cones down from the top to bottom, just like our own occipital cortex. And this is where you can see it. There is image acquisition and reconstruction, followed by segmentation and pre-processing, and then all the way to diagnosis and prognosis. The next important area is natural language processing, in which written or spoken word is recognized by AI. Now, where is this important? This is important in the dictaphone that we use to dictate notes. It's also important in the way I would write a cath report while dictating it into Microsoft Word. So that's natural language processing. And then once we scan the electronic health records, it picks up the relevant information and analyzes that information as well. Now, to develop natural language processing, these are just some of the faculties that are required by AI. And of course, human beings are rearing AI as their own child. So this is, वो जैसे बच्चे को आप कायदा पढ़ाते हैं, तो अभी हम कायदा ही पढ़ा रहे हैं AI को. We can also create personalized treatment plans based on genetic information analysis and then lifestyle factors consideration, and give them a detailed plan in order to get better patient outcomes. Of course, we all know that the data analysis speed and of course data analysis accuracy is mind-boggling. What are the challenges? We know that there are significant privacy concerns. We know that the AI is moving faster than the legal framework it is supposed to follow. So the legal framework has to catch up with AI so that we can have less ethical issues. Of course, if you are looking at different groups, for example, in terms of gender, in terms of race, underrepresented groups, there may be a bias in teaching the algorithms. In my opinion, it should not be man versus machines. There is a time in the very near future that I see where we would have to combine the human expertise with AI. Of course, there is always the role of health professionals. There is a conception that maybe we will lose our jobs. No, we won't, because if you look at the economic aspect of things in this book, it's quite detailed by Dr. Darren, and it will simply generate a new era of jobs. So the jobs will still be there. We will still be looking at radiology images. We will just be looking at them from a perspective of AI. So the doctor of the future will have to learn to use AI, and they will be the better ones. I hope these are not my famous last words. So this, to me, is the cath lab of the future. So there will be procedure precision. There will be patient and operator safety. And how will the AI do this? There will be real-time image processing, there will be optimization of the procedure workflow, and of course there will be decision support algorithms that put us through this. And if we look at the role of AI in coronary interventions, we will be talking about computational simulations, machine learning and deep learning networks combined with or output into augmented reality or virtual reality, and this will all help in procedural assistance. Combine intravascular imaging with AI. We are already seeing that in our OCT softwares, in our IVUS softwares with automatic border detections, plaque calculation and length calculations, and even suggestion of what stent to put in. So there are opportunities for AI in imaging, and of course in the cath lab as well. In imaging, the deep convoluted networks and artificial neural networks help us to identify images. For example, you can identify the kind of coronary plaque with the different Hounsfield units in a cardiac CT, and you can see very enhanced detail of the late gadolinium enhancement in cardiac MRI. You can see the calculation of strain and strain rate by the use of speckle tracking software. So this is already there. We're using it in our daily life. Right, thank you. And I'd like to acknowledge the help of Microsoft Copilot 360 in assisting me to make this presentation. It wouldn't have been possible without the help of AI. Thank you. If there are any questions, I'm happy to answer.
Yeah. I think it's all very interesting. It's say narrow AI, general AI, but since you are talking of future, let's so far what we see when you give an input, it gives an output, all right? But will there be a time that, for example, we as humans, we find something and we generate a hypothesis? Will there be a time that artificial intelligence will be developing hypotheses on the basis of certain knowledge? And how would they design experiments or clinical trials? Because there will be no data. So would they be data generating at any time?
That's a very interesting question. And before I begin to answer it, I'd like to just say something that is almost in parallel. So Henry Kissinger recently wrote a book about AI. It's very interesting. And he opens the book by telling us that the Harvard professors asked AI to develop an antibiotic which would kill any bacteria. The AI came up with a molecule that human beings had never seen before. That molecule was called halcyon. AI analyzes reality that we cannot perceive for now. So it was analyzing, when they looked at all the things that it was analyzing, it was connecting over 2,000 variables in ways which the Harvard professors, and these are really wise guys, were not able to connect, or they had not connected, or even fed that information to the AI. So that's where I want to start. So AI examines realities and variables and connection between those variables that we have not so far been able to perceive. So once that is done, I'm very hopeful that AI will generate hypotheses, because it's already doing so.
But what you're talking about is the data is already there. It has synthesized from what you say 2,000 references or 5,000 references. But something very new where there is no reference. Do you think this will ever be possible?
Actually, so let me go into the depth of what AI did in the halcyon molecule. So they fed it a database of molecules, current existing molecules, antibiotics, a database of microbes. Now, we already have that database. We have not been able to create halcyon. AI did create halcyon because it analyzed those very variables, and then it created an entirely new molecule which does not exist. So that was a simple example that it will generate new hypotheses, because this is exactly what it was doing when it decided to create a molecule that did not exist.
Let me make it. Okay.
Okay.
Yeah.
Because we are able to tame our machine, and Professor Javed Akram's presentation is ready. So I'll request him to please come forward and start his presentation.
I hope for the better luck this time. As I was saying, this is shifting gears because, again, Bismillah Rahman Rahim, and I'll be talking about what I consider is a medical miracle. Why a cardiology conference? Because rare diseases are seen in cardiology specialty, whether they are, like acquired diseases or genetically determined diseases, or pediatric cardiologist would see a lot of rarities in the heart. So that is why it is important to really from my point of view as a physician, it's important to know how you deal with these cases. I'll talk with this very short time allocated to me, I'll talk about the background of these diseases, historical perspective, differential diagnosis, and the miracle which I just said, and then we'll talk a little bit about the genetics. I'll touch upon that, and current scenario, where we are today, especially in a country like Pakistan, where consanguinity is very, very high with cousin and caste marriages, and then the prognosis, publications, submissions, and conclude them. The background is that these rare and mysterious diseases constantly haunt the mankind, and so the physicians also. The world remains the frontiers of rare and mysterious diseases. A practicing physician will come across every now and then a rare disease, and generally they remain undiagnosed and they are treated by quacks, sermons, and so on, because these symptoms do not fit in the common diseases. As a diagnostician, one needs to have an obsessive attitude to diagnose these diseases. Often the diagnosis remains a challenge for a practicing physician who requires a multidisciplinary team, especially the lab workup, especially the next generation sequencing, and so on. Otherwise, these patients, 90% of them in Pakistan, are labeled as malingerers or suffering from a conversion disorder. This is a story, a very interesting story from the inner Balochistan. Jalal is sitting there. He knows Mian Kundi, which is a village of Quetta, south of Quetta. And these three brothers, they would be fine when they get up in the morning, they will play cricket, go to school, and do the normal activities which their age-matched siblings would do. But as the sun set, they would get paralyzed, and they could not even breathe at times, and they could not go to the toilet, they could not eat or drink. So, and the symptoms would start in the second year of life, and two of the siblings, and now the third sibling, had died of this mysterious disease. And they were treated for multiple exposures by physicians, psychiatrists, exorcists, quacks, and sermons, mostly diagnosed as malingerers or suffering from some fictitious disorder or possessed by demons. So this is Shoaib, the elder ones, in 2016, 13 years old, and this is Abdul Rashid, the other brother. And this was very widely, if you Google solar kids, if I can have the sound, sound chala sakte? Sound. Anyhow, this is rural Balochistan, and this is Mr. Bellin. A lot of interest in the media. If you just Google this, you will see all these stories again and again. So in the interest of time, I won't go in the detail of this, but he described it very well for CNN and other things. This was the condition when I saw them in their village, which is Miagundi. And condition, then we shifted them to Shahid Zulfikar Ali Bhutto Medical University, where I was Vice Chancellor and PIMS Hospital. And subsequently, when I took over as Vice Chancellor, University of Health Sciences, they are traveling with me, and they are still part of my biological family in a way. So, in summary, we worked up extensively. I think every test in the world was done. Here at Maryland University, Guy's Hospital, where I trained, we sent samples, EMG, tensilon, adrophonium test, family screening, counseling, environmental center. We thought it could be congenital myasthenic syndrome, hereditary dystonia, Sagawa's disease, a very rare disease seen in families from Japan, but there is no diurnal variation in that. Juvenile muscular dystrophy, connective tissue, familial periodic paralysis. The potassium remained normal throughout their 3 years stay with me in the hospitals. Radiculopathy, spinal dystrophy, primary lateral sclerosis, vasculitis, or Munchausen syndrome, or an undiscovered, understood condition in medical science. For the first time, this was brought to the notice, such a disease, to the medical science, and we peer reviewed it from about 5 major international universities, including my own. And this is when the miracle occurred. So after exhaustive workup for 3 years, I decided to give a therapeutic trial of levodopa at night. When they were paralyzed, so I gave them levodopa, half a tablet, to all the 3 kids. And they were absolutely normal. For first time in their life, they were awake at night, they were active at night, they were able to eat, go, and believe me, they were running around all over the place after nurses, and the nurses were chasing them all the time. And this is what I said was medical miracle, and we called it levodopa responsive nocturnal akinesia. This was the label, but that was not the end of the story. This was the beginning of the story. Now we had to do all the sequencing, also look at the different bioinformatics tool, and sent the samples to Maryland University and also Guy's Hospital and so on. You can Google just Solar Kids and you will see all these movies there. So even he's trying to say that Dr. Akram had never seen such a disorder. And anyhow, exhaustive clinical workup was done at Shahid Zulfikar Ali Bhutto Medical University, PIMS, where me and Akhtar Bandesha worked together. At Center of Excellence in Molecular Biology for phenotypic evaluation, all the electroretinographies, fundoscopies. Maryland University, again NGS and Sanger sequencing was done there. Allama Iqbal Medical College, where I was principal, and NGS data for computation. So we decided to take this was like, looking for a needle in a haystack. because we had these bioinformatics tool that we looked at, and interestingly 200,000 variants were looked at, and we shortlisted one by placing filters, 7 variants which were near to this. Sanger sequencing confirmed in all these 7 variants IVD gene. Now I will talk a little bit about IVD gene. All the 3 siblings affected were homozygous for IVD gene, that is chromosome DNA 3 at position 313, guanine was replaced by arginine and especially affected was chromosome 15 in this case. So IVD gene is a mitochondrial matrix enzyme, and we already know that it causes isovaleric acidemia, which we excluded, by the way. They were not acidotic. Propionic acidemia, autosomal recessive, non-syndromic deafness, metabolic acidosis, systemic primary carnitine deficiency, idiopathic pulmonary fibrosis, all these were excluded. So we looked at 11 computational verdicts, and all of them suggested to us that they are highly pathogenic or disease causing, except for one SIFT which was uncertain. All the 10 were very, very definite that chromosome guanine was replaced by arginine, and in protein side glycine was replacing serine in this protein position. So chromosome 15 was the main culprit, where guanine was replacing arginine, and in the protein side glycine was replacing serine at position 105. So these are the homozygous for IVD gene. These were the affected individuals, and you can see the heterozygous sisters and other brothers, they were not showing any clinical abnormalities at all. So we looked at different species, that whether this has happened in zebrafish, in rodent, fly, and it did not. This was well preserved glycine at position 105, while in these patients at position 105 glycine was being replaced by serine, and we thought this is the defect that is affecting DRD1, dopamine receptor 1 and dopamine receptor 4, and that is what was affecting. So now very recently during Ramadan we visited, when we met Jalal over there as well. We went to this family again, and you can see another child was born. Although we counseled the parents, which was Hashim standing here, that not to have further children till we check out everything, but they have now another child which was 2-year-old and started having symptoms now. So these are the affected children now who are going to school, and they are very much normal. The team found that previously reported kids and the third male sibling had also the same symptom. Unfortunately, 2 months ago they had lost a 3-month-old male boy as well. So this was the clinical scenario of all the 3 affected. We did all the measurements. We shifted them to Sandemannum Hospital, Quetta, and you can see we interviewing each and every family. We stayed with them, and these are their measurements. And this is what we decided in the Sandemannum Hospital, to withhold the dopamine and to give them a matching placebo. But matching placebo didn't do a thing. They were paralyzed and they were unable to stand, walk, or even eat and whatever. So we at Seher time we decided to give them active drug, and then this was the this was taken after. Sorry, the movie is not coming up, but they were very actively walking, this boy and the other boy who were given dopamine at the midnight. I think we are not having any luck. Here you can see them walking with us fine, showing victory sign. So these cases were reported in annals. The media, international media, covered it more than the national media. Guardian, Al Arabiya, all these papers, they covered Khalij Times. And this is our final photograph with them. And I'll always say that in the realm of pharmaceuticals, our true prize is not just in the discovery of new molecules and diseases, but in the impact they have in improving lives worldwide. So that motivates us. That was our reason to come up with something sustainable for these families. So I acknowledge Allama Iqbal Medical College, all these investigators, my team, Allama Iqbal, Maryland University, and University of Baltimore, and so on. So we formed about a year ago a Society of Novel and Rare Diseases, SNARE, of which blazer I am wearing very proudly. It's a toddler society. Only 1 year ago, we conduct grand rounds of different hospitals. We go to these patients and try to make a diagnosis, which might take a year, sometimes couple of years, because it's a very tedious. And we do a lot of research. Our impact factor in rare diseases is, alhamdulillah, coming up very rapidly high. We have access to next generation sequencing, Sanger sequencing. We are a registered company, SECP, Section 42, not for profit. We have the chapters in Bangladesh and also in Sri Lanka. Actually, I'll be going there shortly, both countries. We have collaboration, international and national, European Society of Rare Diseases, and also NOD, National Organization for Rare Diseases in US. We have our own official journal, which comes up every quarter. We allocate fellowships to cardiologists, orthopedic surgeons, eye physicians, because these rare diseases are present across all specialties. So people who are interested, the first conference will be held in PC Lahore on 5th and 6th of September, where we are having specialists in rare diseases from 33 countries. So I really invite you from the core of my heart to be there to support these families. And we have a very active advocacy group led by Aisha. She's mother of a child suffering from propionic acidemia in Gujranwala, and she is dedicated her life to supporting the rare diseases. Visit our website www.snare.live, and this you can see was recently the SNARE was on Al Jazeera TV. Dawn Print also came up with the data that 16 million rare cases are there in Pakistan. World over, there are more than 300 million cases of rare diseases. This is our Masood Sadiq, you all know him. He is our senior vice president. I am the president, and Aftab Mohsin, Huma, and all the genetics. We have 23 PhDs in genetics from either France, US, and other countries. So these are just glimpses of that. So I'll end by saying that our Prophet Muhammad ﷺ said, Allah did not send a sickness except He sent it with a cure. So it is really up to me, you, or everybody together to support these families, because these families are really, I see the suffering. जब मैं गया था कोयटा मियाँ गुंडी में, तो इन बच्चों को उल्टा टांगा हुआ था और जूतियाँ मार रहे थे और नीचे आग जलाई हुई थी. तो मैंने कहा ये क्या है? वो कहते हैं जी बूथ निकाल रहे हैं. तो they are tortured badly, but they do have an illness. अल्लाह ने जिस जो बीमारी पैदा की उसका शफा भी पैदा किया. So then it becomes imperative amongst us. It's not just we जो हमारा ग्रुप है उसमें जेनेटिक्स वाले तो हैं ही हैं, बहुत अकम्पलिश्ड हैं, एडल्ट फिजिशियंस हैं, ऑर्थोपेडिक्स हैं, क्योंकि ऑर्थोपेडिक्स में ऑस्टियोजेनेसिस इम्परफेक्टा एंड सो ऑन, आई वाले हैं, कार्डियोलॉजिस्ट हैं, अख्तर अली बंदेशा साहब हैं, ये बड़े रेयर डिजीज़ में रिपोर्ट करते हैं, जो कार्डियोलॉजिकल रेयर अनोमलीज व्हेन यू डू एंजियोग्राफी और व्हेन वेल्व डिजीज़ मार्फन्स के साथ एसोसिएटेड regurgitations, they all need to be reported. They go unnoticed and unreported, and the result is the family counseling तो होती नहीं है क्योंकि diagnosis नहीं होता, and more children are born, and the burden of rare diseases is huge in Pakistan. Believe me, it's huge, and it's not the one child who is suffering, the whole family is suffering. मैं हमेशा कहता हूँ कि rare diseases are rarely diagnosed especially in a country like Pakistan, and they are rarely treated. But if you treat them, ये आपकी ज़िंदगी का असासा बन जाता है कि आपने एक फैमिली की डायग्नोसिस कर ली. प्रॉब्लम ये है, अज़र बैठा है एंड फॉर्चुनेटली ही इज़ इन द राइट पोजीशन कि इनकी दवाइयाँ भी नहीं मिलती. So we have to really import them all the time. We pull up money from our pockets and we import these medicines because they are not available here. So we have drap मुसीबत डालती है, मगर alhamdulillah we are not giving up on these things. We will continue to support them because they are our children, our families, and I think they need all the support from us. अल्लाह ने हमें अगर अकल दिया तो उसको इस्तेमाल करना है इन लोगों के लिए. Thank you so much.
Thank you. Thank you, Professor Javed Akram, for such an enlightening talk. We are running short of time because next session is Zoom session and the speaker I think is ready. We have just 5 minutes and we can take 2 or 3 questions and then finally concluding remarks from the experts. If no questions, I think we'll move on to the final comments from the experts. Sir.
I think all I can say is that thank God these rare diseases are rare. But I mean, on and off, we have all seen occasional something. But I think this reminds me of one thing. We, in our training days, in student days, we are usually given a distinction. If you can recall small prints of a textbook. Whereas in the Western world, if you talk about small prints, you actually fail. Because they say something that you may never see in your lifetime, or you may see it once or twice. Why do you want to remember it all the time? But anyway, it's a great talk, and I think it's an eye-opener. And anything I can do for these things, I think I wouldn't mind being part of it. Yes, thank you. I think I'll be there.
Professor Khalvar, sir.
Okay, thank you very much. First of all, I think Professor Javed Akram has the ability to surprise us, and he keeps on surprising us. So this is one thing, but I think if we are connecting the two talks, I think these rare diseases become easier to identify and maybe decipher with the use of AI as it develops. So I think that is probably the future where things will significantly be different than what the way we are doing things today. So we should be keeping our eyes open and then mold ourselves to the realities as they come in. Thank you very much.
So final comments, sir.
Javed, being your close fellows, Javed, it's very heartening to know that you went all the way, I think, to the Balochistan and then spent so much of time and your hard work, and then you collaborated with so many people and so many institutions. And it's a great thing, and that's a sadaqah-e-jariyah kind of a thing, and anything that you need our help at any stage, I think we are always be there with you. And thank you very much for presenting this case in this forum. Thank you.
So now I'm handing over the moderation to Dr. Azmat Hayat for next State of Art lecture.
Sir, आप बैठे sir. So before I have the honor of introducing our guest speaker, may I request Jan Nasir Samor to please come and take the chair. Sir, may I request Professor Harun Babar? Sir, come and have a seat. May I request Professor Isaac, sir? Professor Isaac, please. Okay, gentlemen, can we have your attention, please? Let's move on, and we have a very distinguished guest speaker who is on standby and on Zoom. So I myself, you know, I'm Professor Azmat Hayat. I'm head of cardiac electrophysiology at the moment in PIMS. And I have the honor of introducing one of our very distinguished guest speaker. So he is Professor Joan Lee Lin. Professor Joan Lee Lin is a chair professor in cardiology in Taipei Medical University. He is a professor emeritus in medicine in National Taiwan University College of Medicine. He is at the moment chairman and staff cardiologist in Cardiovascular Center of Taipei Medical University. Dr. Junlin is currently president of the Asia Pacific Society of Cardiology. The tenure is 25 to 27. And he's also the president of Taiwan Heart Foundation, currently president. Dr. Lin has devoted his whole of his life to clinical service and basic research, but his special interest remains in the field of cardiac electrophysiology, including catheter ablation of various arrhythmias like atrial and ventricular, and even atrial fibrillation, inherited arrhythmias, and the arrhythmias related to sudden cardiac death. So, not with any further delay, I would request the distinguished speaker. Professor, you have the mic. Please go on.
Yes. Thank you for Professor Asma Hayat's nice introduction. It's my great pleasure and also my great honor to be speaking in this very particular meeting organized by the Pakistan Cardiac Society. And the topic I want to talk about is about atrial fibrillation. And I will try to share my slide.
Sir, you have 20 minutes.
Oh, okay. Okay. Yes. You see a slide yet? Is the slide okay? Yes. Can you hear me?
Yeah, we can hear you, but can't see any slide if you are presenting one.
Okay.
We can hear you very, very nicely.
Mm-hmm. Let me see. Let me see.
I think.
Also, can you share it?
Sir, Prof, we can't see your slides. Do you want to slide share?
No, one moment. Maybe I can try again.
Yeah, I think something has come up, so we can see the slide now. It's Zoom.
Let's see.
Yeah,
okay.
We can see.
Can you see the slide? Okay. Can you see it? Is the slide ready yet? Can you see the slide yet?
Prof, your slide is actually, the first slide we can see is just a white background with Zoom written on it.
Oh, okay. What happened? Shit.
The top one.
Yeah.
You need to.
Okay, let's see.
So till Professor sort it out, basically his talk is on his strategy of contemporary strategy regarding antiarrhythmic drugs, ablation. Prof, we are waiting for you. You please go ahead.
Okay.
But yeah, we can see you very clearly. We can hear you, but can't see your slide.
सरबंदेशा
वो किसी को आईटी वाले को कैंडिडेट So I was just trying to help him out. I just said that he is going to speak about the atrial fibrillation. It's a hot, burning topic, and I've known that he has worked a lot on it. And he has got, in fact, to be honest, he's involved in lots of research and registries, particularly on these atrial fibrillation. So he has been actively involved in multiple clinical trials like Active Trial, Athena Trial, the Compass Trial, Raft AF, then Panorama, and Dive HF. In fact, Panorama was one of the huge series of device registry and vis-a-vis atrial fibrillation. Sir, Prof, you need to press the share button. Can you do that?
Let me see. Let me see.
There should be a green button.
Open the presentation in the background and then you click on the green button and the share green.
Okay, so Prof, our IT team tells us that you open the presentation.
Okay.
And then there should be a green, on the Zoom, there should be a green button, written share. Yeah, a window should pop up, and then you select it and it should share with us.
Yeah. I should practice first.
Professor Harun sir, may I have your comments on any question on atrial fibrillation?
सर ये दुआ ही कर सकते हैं फिलहाल तो लेकिन सर atrial fibrillation के बारे
Coming
में
to atrial fibrillation,
प्लीज सर आप बताएं जो EP स्टडीज कर रहे हैं और एबिलेशन कर रहे हैं उसके ऊपर कोई नई चीज इन एबिलेशन क्योंकि एबिलेशन में भी बड़ी लेटेस्ट जो मोडेलिटीज आ गई हैं उसके बारे में जरा बताएं
Ji sir, I'm sure so Professor will also be talking about the theme would be to catch it early. I'm very sure that he's going to speak about this. So the theme would be to catch atrial fibrillation as early as possible. Because if you catch it early, and particularly these paroxysmal atrial fibrillation. So there is a huge chance that the substrate can be ablated and the LA can be prevented from being gone into fibrotic, scarred, and the remodeling. So the theme nowadays is, and especially with these new, as you said, the new therapies, like we had initially it was laser therapy, but then we had cryo, and cryo is quite huge now, big numbers. Of late, there is a newer technology come up which is called pulse field ablation. It's a newer mode of energy where the source of the energy to ablate the tissue is water electrolysis, and it's a very safe, they claim it's a very safe therapy compared to cryo and then the earlier mode of ablation, which was the laser ablation. So this is now coming up, and it is one or two the major manufacturers, they are actually projecting their machines regarding this aspect. We will have soon one in Pakistan as well. It will, as I said, hopefully be helpful in reducing the AF burden. But till he gets his slides on, I would always say that before ablation, I am a very strong proponent of a few preventive measures, especially in atrial fibrillation, especially in paroxysmal atrial fibrillation. And this I have found, I think we have got something. Good. Professor, we have seen your first slide. Go on, please.
Okay.
Go on, please.
Okay. I would thank you for all your waiting and sorry about the technical problem. The topic I'm talking about is the contemporary strategy in AFib management. What I'm focusing on is the early anti-respiratory drug or early CAS ablation, and maybe the better or best will be early rhythm control in AFib management. And this is the slide that we usually see when seeing the patient in the clinic. We see this slide showing the atrial fibrillation, and we will say that the patient will ask you what you are going to do with it. And sometimes the patient with the technical advance in recent years, they can have smartphone, they can also have the patch or the chest band or some rings to show you some needs about atrial fibrillation. So that's a question when you come into the patient come into your clinic. Normally you're electrophysiologist or not. So for this patient, first question coming to you will be that is this in this first diagnosed atrial fibrillation, is this really an early atrial fibrillation? Or maybe next question is coming to you is this first diagnosed atrial fibrillation is really a kind of a paroxysmal atrial fibrillation, or is actually only part of the persistent atrial fibrillation, or even a permanent atrial fibrillation? With different type of atrial fibrillation, what should we do with these atrial fibrillation? As clinical cardiologists, we should think about all these questions. But first of all, about the management of these patients, we have the problem that we have the only anesthetic fibrillation in the first place. We classify them by the duration. Usually less than 40 hours, call it paroxysmal. More than 1 week, or require cardiac version, call it persistent. Even longer time to 1 year, call it long-standing. And sometimes you cannot do anything about it, even by cardiac version, we call it permanent. But this is a quite arbitrary method to classify the atrial fibrillation. By this method we can see that by a more detailed recording of atrial fibrillation for a longer time, by either loop recorder or the CIED, the pacemaker recording, we notice that the so-called atrial fibrillation actually is not very easy to differentiate. Take the right side figures. You said that the red color means it identifies as persistent atrial fibrillation, and the blue side is called paroxysmal atrial fibrillation. For these patients, you can see that even with very high atrial fibrillation burden, that means the total time the atrial fibrillation has been occupied during the observation period. You can see that it's actually, it could be still very long atrial fibrillation, but you should call it paroxysmal or not really calling it persistent. That means that we don't really know how much of the time the patient in atrial fibrillation. And this is a very important question because we know that from all the in-body device recording, we notice that with more the time spent in atrial fibrillation, that means the atrial fibrillation burden with one less than the 0 time in per day, or less than 5%, or 5 to 98% a day, you may see that the difference of the all-cause mortality, all-cause hospitalization, ischemic stroke, or cardiovascular hospitalization is all increased very steadily. And if we count it like each episode, if it's less than 1 hour, or 1 hour to 24 hours, or more than 24 hours, it's all showing the same thing. That means the more the time the patient stay in atrial fibrillation, the patient will more comorbidities or in the bad outcome in the long run, including all-cause mortality, cardiovascular mortality, or cardiovascular hospitalization, ischemic stroke. And this situation can be even worse when you're looking at the patient. If they have the patient of the hypertension, age more than 75, TIA or stroke or COPD or heart failure, so-called HUSH score, you can see that these patients with higher score, you can patient will go into more prolonged atrial fibrillation. And during the progress of atrial fibrillation, that's very common in those patients with paroxysmal atrial fibrillation. You can see that during the operation, the rate of the during the progression, you can see that the patient can have more events of side effect because ischemic stroke, major bleeding, all-cause mortality, or hospitalization for heart failure, the incidence all increased. So atrial fibrillation itself is kind of progressive problem, and you cannot really tell it from your first time of ECG. When facing this patient, when in the clinic, what we can do for the cardiologist is first we maybe think of maybe we can try anti-arrhythmic drugs. Or for the old experience, we noticed that the drugs we use for the atrial fibrillation reason control, like amiodarone, sotalol, or cross-1C freckanine mainly, we can see that they actually causing more problem in all kinds of cardiovascular hospitalization or cardiovascular deaths. That's what affirm study shows us. And further on, we have more technique on the CAS aberration. We focus on the arrhythmogenic brain focus, or even the substrate in the posterior wall. You can see that actually it's the way we are doing the CAS aberration, either by radiofrequency CAS aberration or by cryo aberration, or even the more modern pulse field aberration. This is the technique we are going to use for the removal trigger and the substrate. But the initial result from the clinical follow-up H2V recurrence actually is not very good. So that's meaning that you have CAS separation as reported previously by Carl Cook or by Heisel Good. They also group, they're showing only that the first year, maybe you have 70%, 80% of atrial free, but after second year, it may drop to 50 or 60%. The third year, it may drop to 30, 20 to 30% that can be free of atrial recurrence. So that's causing the problem. So in the beginning time, we always thinking that maybe this patient, when you first this patient, we will just start with the upstream therapy to treat their concomitant comorbidities, and they can start the anticoagulation if the CHOP score is high, and they will start to control the rate first. So the rate first control actually in the initial therapeutic decision scenario that we are using in the beginning. And later on, when we see if that control is still paroxysmal, we try anti-arrhythmic drug or even CAS separation. But even going to the persistent, then the role of this drug may be increased, but still we put everything on rate control as the first decision-making for our clinical practice. That's the situation before the EAST-AF study. And this is the time we're coming up with the EAST-NET4 study. I think it's a very important paradigm shift related study. It's showing that the early reason control for atrial fibrillation will really reduce the long-term cardiovascular event. as a hard endpoint. So in this study, they separate all the patients with AFib less than 1 year as noted from their clinical history. They separate one group with recent control, the other group with usual care. Usual care, usually they use rate control by digoxin, by beta blocker, or by non-hydroxypyr beta calcium blocker. For the recent control, they use the propafenone, bradykinin, and amiodarone as zolnidalone for the control. The most popular one they use actually is bradykinin, and second coming with amio and also zolnidalone. And this is the initially started. That's a study that has been going on for a long time, nearly 7 years. So in this period, you can see that they use these medication to reason control the patient or just simply by rate control. And they show very important result. It can show that the first primary outcome, the primary outcome, including those deaths from cardiovascular, stroke, hospitalization for worsening heart failure, or hospitalization for acute coronary syndrome. Altogether, called the first primary outcome. This outcome is actually reduced after 7 years of observation. This is the very first study showing that you have the reason control, you can have good, really cardiovascular outcome for patients with atrial fibrillation. And this is the second outcome found in the only quality parameter SF4012 or EQ5D. They all show the same improvement. So these patients, they do improve in quality of life and also the heart outcome of the cardiovascular disease. This figure shows simply that show after 7 years observation, early reason control policy indeed improved the patients. And the sub-analysis, these patients found that those patients with high CHABA score, that means the high comorbidity burden, they can benefit further from the early reason control. And also interestingly, also showing that patients with nearly no symptom or very mild symptom, they are also a very good, very similar outcome improvement as those with moderate or severe symptomatic patients. So that means with or without symptom, your atrial fibrillation is coming very early within 1 year with good reason control method, mostly by anti-arrhythmic drug and very few by cath ablation, they can achieve this result. Almost at the same time, we have another Cabana study. This study, they also tested the effect of the cath ablation on the anti-arrhythmic policy for these patients with early atrial fibrillation. They test on the quality, the mortality, stroke, and non-bleeding, and all the cardiac arrest. In this study, for about 5 years, they can show that no difference between the two groups. That means the drug therapy and cath ablation, they have the same benefit or same outcome as, with each other. And this result, interestingly, with the quite more comprehensive ECG monitoring data, they can see that those patients with paroxysmal, you can see that both the drug group and the drug group and also operation group, they also reduction the cardiovascular atrial fibrillation burden. And for those with a persistent AFib, they can also show the difference. And the difference seems that take the drug, the blue bar, you can see that with this drug, even in persistent AFib, you have nearly half the instant atrial fibrillation burden. And for paroxysmal part, it's also very effective. So that means that something is inside of it, even you did not show the difference between the two methods to control atrial fibrillation. And the group, the quality analysis, you can see that with less the atrial fibrillation burden, you can see that the cath ablation group is actually doing much better than drug. And this is the analysis test that showing that with a severe, more prolonged recording by loop recorder in patients with shock-resistant persistent fibrillation. That means these patients are difficult to be converted even by cardiovascular conversion as close to the permanent group. And this kind of group, they show it by atrial fibrillation. They can also show that up to 3 to 6 months, 6 to 9 months, or up to 1 year, you can see that atrial fibrillation burden is reduced significantly, and the quality of life is improved. So even with very resistant, looks very persistent atrial fibrillation, if you can have a good cath separation to isolate simply the pulmonary vein orifice, you can have the result. And this detail shows that those patients with good outcome, you can show that they don't see any atrial fibrillation burden. They call it atrial burden in those affected group. Even those with less affected group, they also show quite great reduction in the atrial burden. And so the violin plot is show that the reduction of the atrial burden founded by the loops recorder. That's the most accurate time you can get over this. For this study, we can learn from this study, we can notice that with the rhythm control approach for these patients with atrial fibrillation, normally seen in the clinic, it's paroxysmal, persistent, or maybe even some permanent cases, you still have to work very hard on rhythm control. And rhythm control, you can really, by the drug, they can control all the triggers and all the substrates, like even modulate the autonomic system, like in cath separation. The method of cath separation of anti-disease drug, it actually reduce the atrial trigger and also re-entry circuit and slow down the atrial progression. And the effect is really showing us that you should go more actively to rhythm control, not just very conservative rate control for these patients. So taking it from the ACE, AFNet, EHRA conference, you can see that for those patients, if you have consumer identified like by your smartphone or by all the recording device on you, you can see those patients coming to you with the first record HP. You should consider them as a kind of potential patient with atrial fibrillation. Maybe they are paroxysmal, maybe they are persistent, maybe they are only early atrial fibrillation. So in this patient, they should go to more detailed evaluation, taking 5 or 7 days of continuous ECG monitoring to see if there is atrial recorded. It's a significant long time. And those patients, sometimes you will take those patients with high risk group. They suggest that those patients more than 75 years old or more than 75, but also with resistant heart failure, diabetes, hypertension, stroke, or myocardial infarction, or those patients with high EMP, or those patients with a lot of alert for the wearable devices. These patients also come into your clinic and to see they can verify it by the continuous ECG. If we can recognize and verify it as early atrial fibrillation, then you can start your treatment of these patients. So for these patients, actually we noticed that the situation that we have been changing in our concept when you're managing these patients first time atrial fibrillation. And this is a very important issue for clinical cardiologists. And as a cardiologist, when you see the patient for the first time and show you the atrial fibrillation lead, you should go on to try to manage the patient starting with the rhythm control. Of course, you have to treat the patient with anticoagulation to avoid this systemic embolism, or you can treat the cardiovascular risk factor as a comorbid factor so that we can control the underlying heart disease, so that we can have the background be controlled, and also with rhythm control theory, we can reduce atrial fibrillation burden. This is the most important thing that we have seen from the ESFNet. We have a lot of technique to do the cath separation. Cath separation is, of course, a very important part of the rhythm control, especially those patients with very frequent high loading paroxysmal fibrillation or with persistent fibrillation. Without cath separation, it won't be effective to control rhythm control. So we can go on to these patients, not just so passively going on to rate control only. So facing this patient, even with a clinical cardiologist, not exophysiologist, you should go on to treat this patient with more aggressive control. And this idea, I think, is a very important part of my presentation. I want to share if this kind of concept could be moved on to all the parts of the Asia Pacific region, because we have a big organization, big population in this area, and hopefully we can have a more chance to share this idea to all the patients here.
Thank you so much. Thank you so much, Professor Lin. If we have time, Professor, I have a request for you. You should please keep on staying. We soon have an inauguration ceremony where you are expected to have a couple of words and to say.
Okay.
Sir,
That's
from
my
the
honor.
panel, any question to Professor? So we have one question for you.
Professor Lin, this is Dr. Ishaq here from the audience.
Yes.
Thank you very much for an excellent presentation. Atrial fibrillation is a very vast, very interesting subject. In our society, is somewhat underdiagnosed, undertreated, with a lot of complications, including loss of life. My humble question is that people who are stable on medical treatment, and with drugs we had a very good result, you see, is there a place to push them for ablation, or they should be all right kept on medical treatment? Because in our country, people are afraid of procedures. And if we have a person who is well controlled on drug and antiarrhythmics, then does it make any sense to insist on intervention? Secondly, you mentioned about rhythm control. In the presence of valvular or structural heart disease, how can we achieve rhythm control? Thank you.
For the first question, and I think that if the patient is really well controlled in clinical condition by the current by his or her current management or medication, say if they are patients that they have good EMP, they have no progress to the atrial fibrillation heart failure symptom, and they have a good anticoagulant control and can avoid the embolism. Of course, we can stay on it. Today, I'm mentioning how mainly is about those patients when you first see at the clinic, you don't really know this patient is how long, what has been going on in the past. In this patient, we should try our best to control rhythm. Control rhythm, you don't really have to go to cath ablation. You can go to the antiarrhythmic drug first. And what we have here for the ESF, they have the 1C drug. They use a lot of flecainide. And in my country, actually, we are using more propapanol. And also we have the amiodarone and also the dronedarone. Sometimes you want a rhythm control, you can combine the 1C drug with group 3 drug. That can better control rhythm. Because if they can resume in sinus rhythm, all the comorbidity, all the adverse outcome will be reduced. As to situation of valvular heart disease, valvular heart disease that had to be differentiated between those rheumatic and non-rheumatic. Rheumatic heart is more difficult because it's a kind of inflammatory procedure and a lot of myocardial scarring in the atrium and in the ventricle. It will be more difficult to have the result by cath ablation or by drugs. But still, we do have observed a lot of very interesting papers from the Southeast Asia, also in South Asia. They're showing the effect of cath ablation plus antiarrhythmic drug in restoring sinus rhythm. The others, those patients, non-valvular heart disease, non-valvular atrial fibrillation, I think it still have to go on to rhythm control together with cath ablation. With the two approach together, with the better in sinus rhythm, you can reverse the valvular heart disease process. say in those patients with atrial fibrillation. So I think the kind of the therapeutic scenario change is actually a kind of a concept revolution for us, even for doing all the cardiologists or electrophysiologists. Post cath ablation itself is a kind of a quite a long-standing procedure and quite a expensive procedure as we know energy, new energy source coming on, such as the cryo or those with PFA. But the basic principle is still the same. You still have to, you only have to focus on the human vein isolation. That's the focus part. Because the other substrate part, additional ablation, is did not really help very much in the long run.
Thank you.
Professor, you have one more question.
Professor Len, it was an excellent presentation and we learned a lot about atrial fibrillation, especially as soon as it should be converted to the normal sinus rhythm. And I think that should be the take-home message. But what I would like to ask yourself and also Professor Azmat as well, that in people who have permanent AFib, who are in permanent atrial fibrillation according to the time period definition, and if they are offered catheter ablation, will they be in a better position? Will they respond? And what will be the rate in which they will remain in sinus rhythm?
Yes, this is a very interesting question. Actually, in recent years, when we have more and more reports from the root recorder, we found that those patients we have been trying a lot of time cannot convert it, those persistent fibrillation. Sometimes we can call it permanent fibrillation. But you are very surprised to find that some of the patients, even with the observation natural cause, they can still have a window to go back to sinus rhythm. So estimation, how is to call permanent is sometimes we can leave some chance for the patients. So what we can do is that maybe we can still go on the cath separation. We eliminate the triggers, eliminate the substrate as much as we can. I think that will help us very a lot. And I think there's still a chance on it, of course, chance less. But for those patients with really permanent fibrillation, we in that case, we will call it a rhythm control, we only by rate only. The rate, we control it rate at a rhythm rate at about 60 to 7 to 90 or 80. And we to keep a better shape now to go into the HEP, then those patients will be in better shape. Now we have some drugs for HEP, and those drugs may help us for these patients and to reduce the cardiovascular outcome. And of course, for these patients, the permanent anticoagulant use is very important.
Thank you.
आपका
input भी sir. Your input.
So I think what Professor is saying, I'll just put it in a brief, so 2 words. One is technically it is not labeled as permanent unless AF ablation has been offered, number 1. Number 2, there are huge studies and data which shows that even with permanent, so-called permanent, if you do ablation, you reduce the substrate, modify the substrate, people have tended to do better. I think that's what the brief summary, I think, would be what Professor is saying. Yes, sir, go ahead. You have one more question.
Actually. No, not for Professor Lin Azmat.
Yes,
just
no problem.
So go ahead.
Just want a comment from you. In your practice,
yes.
Naturally you get referrals, you see. What's the attitude of patients accepting ablation therapy versus medical treatment in your own practice?
Prof, I've been...
It's for you.
When I first see the patient, 80% they won't take the cath ablation. They will say, I'll stay on drug first. So I've been using a lot of drugs, the anti-disease drugs, try to convert the patients. Actually, when you really go on anti-disease drug use, you can have very good result. And I think that's a very important thing. I don't really go directly to a cath ablation for most of my patients. And it's also, that depends. Some of the doctor, they really love cath ablation, maybe. But as you said, cath ablation, the facility is not always available. And or maybe only several hospitals only in a big metro area. So still, it's a quite time-consuming procedure, and also in Taiwan, it's also getting very expensive because a new ablation device, a new energy source, a new mapping system. So it's not very practical to ask every patient to go to cath ablation for early AFib. That's my own opinion.
Prof, thank you so much. I think you just be with us, and the inauguration ceremony is about to start. Please remain with us, and please we make sure that the internet connection is all intact. You'll be asked to have a couple of words actually. So just a quick answer to your question regarding the acceptability of AF ablation. So all I can say is over these years now, I have seen the number rising day by day. And the reason is, the three reasons. So one is, generally people are getting more aware of it. A, because of the stroke risk. And B, which is very debilitating. And B, the technology and the safety and efficacy of the procedures have enhanced very much. Particularly our younger colleagues who have trained from abroad, they are too good in AF ablation. So for paroxysmal AF, I would always strongly advocate that if AF ablation is offered, one should accept it. And once it is sorted out, AF ablation is done, people tend to stay in normal sinus rhythm for a very long time. Thank you so much.
Thank you very much.
Distinguished guests, esteemed faculty, and dear colleagues, good evening, everyone. I, Dr. Ramshesh Tyag, Resident Cardiology PIMS, is honored to welcome our national and international delegates in 25th Annual Cardiology Conference. Pakistan Institute of Medical Sciences is privileged to host this auspicious Silver Jubilee Conference. This conference has served as an invaluable platform for clinical cardiologists, researchers, and professionals to explore the latest advancements, challenges, and the future directions in cardiovascular medicine, fostering collaboration and knowledge exchange among experts around the world. I want to extend my warm welcome to all delegates, speakers, and sponsors on behalf of the organizing body PIMS. Your contributions are essential to the success of this event. This year, the focus is centered on the role of devices and imaging in the cardiology practice, a field of recent advancements and integrated artificial intelligence. I am delighted to introduce our chief guest, Major General Azhar Mahmood Kiani, Executive Director of Jhelum Cardiac Center, Chairman of National Intervention Cardiology Board, former Commandant and Executive Director of AFIC, former Executive Director of Rawalpindi Institute of Cardiology. His dedications to patient care and commitments to advancing cardiomedicine health are truly commendable. Sir, please join us on the stage. I am honored that President of the Pakistan Society of Cardiology, Professor Rajkumar Sachdevani, Professor Cardiology at Shaheed Mohtarma Benazir Bhutto Medical University, former HOD of Cardiology, GMC Sakkar. Please give him a big round of applause. Next, I would like to call Professor Bilal Mohyuddin, President-elect, Professor Cardiology in Fatima Jinnah Medical University, Executive Director in Pakistan Institute of Cardiology. We are honored to have you. Please join me in welcoming the driving force behind this conference, our esteemed convener, Professor Akhtar Ali Bandesha, Professor Cardiology BIMS. Your tireless effort has made this conference a reality. We are privileged to have Professor Rana Imran Sikandar, Executive Director of PIMS, HOD of Anesthesia and Clinical Care. He'll be joining us soon. Now, I would like to invite Secretary of the Annual Cardiology Conference, Professor Fazil Aziz Mia, Professor Cardiology PIMS, a brilliant mind in the field, always striving to improve the patient's outcome. Give him a big round of applause. And now we have Secretary General Fawad Farooq, Professor Cardiology, NICVD. He is not only highly professional cardiologist renowned for his clinical expertise, but is also excelled in digital medical education. Please give him a big round of applause. Let's begin this conference with the most precious, golden, and the holiest words the mankind has ever known. I would like to call on stage Dr. Naveed Hussain, Fellow Interventional Cardiologist.